My name is Penny Schaefer, and I'm Program Director for Health and Human Services here at Johnson County Community College. It's a beautiful morning, and I am so pleased to be hosting this absolutely fabulous program back in the swing. The UNELs have brought a wonderful lineup of speakers for you, and I'm going to introduce Bob UNEL this morning as your MC. He is going to introduce his wife, Barbara, who is, please stand up, and her passion for surviving breast cancer was the impetus for this whole program coming. We have given you the evaluations, which we will collect back at the table where you signed in this morning, and we'll have your certificates for your CE here at the end of the day. Restrooms are down here at the end of the hall. So please welcome Bob UNEL, your MC for the day.
Thank you, Penny, very much. Can you all hear me okay? Okay, great. Well, you already introduced Barbara, so now I don't have to introduce Barbara. And Barbara is going to be a little later on the program, and I promise you I will give her a full introduction. Okay, what's immediately apparent to me is that all being in healthcare, you've had quite a week, and you all look a little exhausted. But I know it's not from your jobs. It's from the Royals. And I feel the same way, but we're going to get through this, right? And we're going to win the World Series, right? Okay. All right. Okay, well, welcome to you all. This is a very exciting time for Back in the Swing and this amazing faculty that we're going to introduce you to today. And that's my easy job. I just get to introduce these wonderful people who have all been pioneers, not just locally, but nationally, in a whole movement which started 15 years ago or more to bring continued medical care to breast cancer survivors so that they just didn't, after treatment, get sent home and said, you know, come back in 3 months, and you'll hear all about that. But I think the best way to show you and try to describe this gap that we, through a personal journey, recognized in healthcare. I'm going to show you a little video, if you don't mind, and I think it does it best. And this is Care One, right there.
Well, hi, Sally. Look, you've come to the end of your treatments, and your tests look really great. So we'll see you back here in 3 months for follow-up scans, and you can go ahead and get dressed.
Okay, but what about now? Today, tomorrow, the next day? I'm feeling pretty anxious, and I have a lot of questions.
We can talk about all that when you come back for your scans in 3 months.
I can't believe that I have to wait 3 months to find out if I'm doing everything I should to stay healthy. I thought today would be the happiest day of my life, but right now, I'm pretty freaked out. These doctors and nurses have been by my side for months, and now I don't know what to do. They're telling me to come back in 3 months, but I have so many questions about what to do now. What kind of food should I eat? Is it okay to exercise? How do I get my strength back? I can't believe that I'm just supposed to go home, and without a plan to help me recover. We had a plan to help me get rid of the cancer. Now, I have a whole new set of worries and questions. Do I really have to wait 3 months to get the answers?
Okay, so that was about 15 years ago, and quite honestly, that's the reason Back in the Swing was founded. We saw this gap. We partnered with some fantastic healthcare providers throughout this community. And as some of you know, through our retail therapy events, we collaborated with retailers, shopping centers, amazing supporters, sponsors, just a great collaboration. Even the media collaborated citywide, and a lot of work has been done the last 15 years, and you're going to meet some of those people who have helped us do that work. And as a result, what's happening is healthcare is going a new direction. There are people who've done the work we're doing that we've partnered with around the country. People have come to Kansas City to see what we're doing here. And now I'm going to show you where we're going and why I think you're here today. And that's this care number 2, please. Over here at the top.
Hi, Sally. Good to see you. I know you're coming to the end of your radiation treatments, so let's talk about recovery and managing your side effects, including the lymphedema and physical therapy for the neuropathy in your feet. Okay, I've created a survivorship care plan here based on the surgery, chemo, and radiation that you received. Your exact diagnosis is here in the plan as well, and a nutrition plan, exercise plan, all individualized for you to strengthen your bones, your immune system, and help prevent the recurrence of your cancer. Let's go over this, okay? Let's answer your questions. And, even though you won't be coming here as often, I want you to make sure you feel like you have your medical needs taken care of. Our survivorship care is as important as our treatment services. You and I are a team, and we're going to get you back in the swing.
What a relief. I have so many questions.
Okay, so now I've got us back on schedule, and I want to introduce someone to you who is actually delivering this type of survivorship care at the Breast Cancer Survivorship Center at the University of Kansas Cancer Center. Her name is Lori Rinaldo. Lori, she is passionate about survivorship care issues and providing thorough and accurate education to her patients. She is certified in lymphedema management and provides baseline evaluations for patients at risk for post-surgical related lymphedema. She is enthusiastic about the treatment of breast cancer and the enormous advances medicine continues to provide for patients affected by this disease. She is a recipient of the 2011 Hematology Oncology Nurse of the Year Excellence Award and the recipient of the 1992 E. Jean M. Hill Outstanding Clinical BSN Student Award. She is the chair-elect of the Oncology Nursing Society National Certified Breast Cancer Care Nurse Test Development Committee. And
Translate that 14 times.
Wow. And she told me, I told her to help manage her expectations, that she was up at 5:30 making cookies for one of her grandchildren's birthday party that's happening today. So here's Lori.
Okay. So, thank you. It is great to be here. It's great to be in healthcare today, and it's great to share some information with you. So please, there's going to be a little time after I talk that I'll be able to answer some questions. I have about 60 people coming to my house at noon for a dual birthday party for my 6-year-old and 7-year-old grandsons. So I was up making cupcakes. 60 cupcakes that look like skeletons this morning. So, but this information is near and dear to my heart. If anybody knows me, they know this has been kind of our goal and our vision, and so it's actually become a reality, and that is amazing. So let's get started. So today we'll provide you with some of the demands of cancer survivorship, recognize the late effects of breast cancer treatment, look at the accreditation standards that are integrated into practice today, understand how survivorship care plans can promote and contribute to long-term health and integration, especially into our electronic health record. So that is one of our biggest challenges at this point. Delivering multidisciplinary survivorship care, what does that look like? It's certainly not one person alone. It takes a lot of people to make this happen. And then genomic test and next steps. Where do we go from here? So who is a cancer survivor? And that's an interesting definition, you know. Certainly, according to the NCCN definition, a cancer survivor is anyone who has been diagnosed with cancer from the time of diagnosis and for the balance of his or her life. So it's not a point in time that at 3 years or 4 years or 5 years or 10 years, you say this patient is a cancer survivor. It actually begins at diagnosis. And I think that first video really demonstrated where the patient is in thinking, okay, my acute phase of treatment is over, but what do I do now? So estimated and projected number of cancer survivors in the U.S. From 77 to 2022, you can see it just keeps going up. And that is exciting. That is exciting for healthcare providers, for patients and families. Our treatment modalities are so advanced. Our targeted therapies are so unique. And it's an exciting time to be taking care of cancer patients. But as we develop and as we learn and as we improve survivorship, we have more patients that are out there in that continuum gap. And those are the patients that really need our attention. A growing population, again, 3 million breast cancer survivors in the U.S. Approximately 29% of all cancers diagnosed in 2014 are breast cancer. So it's a lot of patients being diagnosed. Great new modalities to diagnose them. We're diagnosing them earlier. Therefore, they're living much longer. Their outcomes are better. Their prognosis is better. But that doesn't mean that the effect of our treatments is any less. And I think that's what's really important to remember. In 2014, an estimated 232,000 cases of breast cancer will be diagnosed. And in addition to that, another 64,000 about of the non-invasive breast cancers, which get a lot of the same therapies. Maybe they don't get chemotherapy, but they get, you know, they'll have to go through surgery. They may or may not have radiation. If there's lymph node samplings, they may develop lymphedema. So there's still issues. And although it's non-invasive and the likelihood of it spreading or taking their life is very low, they still have a lot of results from those treatments. The majority of patients will have early stage disease, and our treatment continues to improve. 80% of women diagnosed with breast cancer will achieve extended survivorship. If you look at the graph there, just the age of diagnosis, as you see, I can't see because I'm with my little bifocals today, but the majority of our patients are 65 and older, and that's still true. We definitely see patients between that 40 and 65 years of age. That accounts for about 35% of breast cancers that are diagnosed. And then we have that very small amount of patients that are young as well. Estimated number of cancer survivors in the U.S. based on SEER data in 2009, and you look at all the different types of cancer, that purple or light blue, I guess it looks like up there at the top, is female breast cancer, again about 22%, and this is 2009 data. We're estimating that could be up to about 29% of all cancers. So in your practice, what will your survivors be worried about? And most survivors, the first thing they say is, what do I do now? And when is it coming back? Is it coming back? What will that look like? What am I supposed to watch for? And where will you be when I need you? And certainly, while it often does not return, it's important to talk with your patients about the possibility of that happening and those signs and symptoms to watch for. So when a breast cancer survivor is in my clinic, and I'm going to use a lot of personal experience because that's what I know, and I'm talking to them about what to watch for, and I'll show you kind of a snapshot of one of my clinic notes. But, you know, head to toe, I want that patient to know what to watch for. I want that patient to understand that a severe headache that doesn't go away needs a phone call to me. Unexplained nausea, vomiting, call me. Unexplained fullness in the abdomen, changes in your bowels. This is the whole person. It's not just about if there's a new lump, of course call me. But I want that patient to be empowered about other things to watch for. Bone pain. And you know, that's an interesting little scenario, because what do? We give patients treatments that cause joint pain. Aromatase inhibitors are notorious for causing joint pain. The Arimidex and the Femara and the Aromacin and the Faslodex and all these endocrine targeted therapies that are very necessary, but they can cause joint pain and bone pain. So what's the threshold? You know, and I like to tell my patients, if you have a pain that's right here every day, you can point to it no matter what you do. You can't explain why it's there. You've tried Tylenol, you've done this. It lasts for more than 2 to 3 weeks and your gut's saying something's wrong, call me. Knowledge is power. Shortness of breath or difficulty breathing, persistent headaches, coughing, rash, changes in the way their breast looks. And you know, there's a lot of controversy about teaching self-breast exam. And the patient never even has to touch their breast to examine their breast, but empowering them, if they're uncomfortable with that, you know, a lot of my patients say, oh, I wouldn't know what I'm feeling, even though you've told me 100 times, I'm scared, I don't want to feel the tissue. I encourage them to do that, but also look in the mirror. Raise your arms above your head. If you notice dimpling, puckering, a change in the way the nipple looks, nipple discharge on your gown or sheet in the morning, pain that's unusual, a bulging in the breast, you know, your bra fits differently suddenly. Your right breast is much larger than the left breast. The nipple now looks inward instead of normal. Those are things they can watch for, and they've never even touched the breast for a physical exam. So just again, empowering patients to know what to watch for. Electronic health records are beautiful things. It allows for communication between providers. It impacts our care of patients in a very good way. Sharing information is critical, but it's challenging, especially with survivorship care plans. Because right now all we have is something that has to be manually inputted. But I've come up with a workaround for our clinic, and I use smart phrases in our electronic record, and I've built templates that fit specific patient scenarios. Someone's received a cardiotoxic drug, I have a smart phrase for that, what to review with the patient. If a patient's received cytotoxic chemotherapy that has a risk of a myelodysplastic syndrome or a secondary leukemia, what to watch for. And so this is just an example of one of my clinic notes. Postmenopausal status, we're addressing that bone health. We'll repeat her bone density in August of 15. Reviewed signs to watch for that could indicate a local or distant recurrence. Signs and symptoms of a local recurrence, watching for any kind of change, nodules on the skin after mastectomy and reconstruction, new areas of thickening along the scar. Regional recurrence, watching for any lumps around the neck or in the armpit, persistent pain in the arm or shoulder, sensation changes in the arms or hands, and distant recurrence, again, an unusual chest pain, bone pain, persistent cough, difficulty breathing, loss of appetite, and you can read those there. When to call our office. I think that's a very powerful statement. These are things you're going to watch for, and this is when you need to call us. And the clinic note is mailed to the patient following their visit. So they have their plan at home in their hand. Follow-up care for breast cancer survivors. Certainly we want to monitor and treat symptoms. I think what's very important is that it's individualized, it's patient-centered. Our patients are not in a cookie-cutter formation. Our patients, because of the way things have drastically changed over the 21 years that I've done this, when patients were diagnosed with a breast cancer in 1993, when I first started taking care of breast cancer patients, everybody had the same drugs. Everybody got adriamycin cytoxin, everybody may or may not have gotten a Taxol or a taxane, and everybody got a mastectomy, and everybody had all their lymph nodes removed, and everybody went on tamoxifen if they were estrogen positive. And that was about it. Now, the individualized care has created so many different types of treatments that in itself brings so many different types of side effects and things to watch for. So individualizing that care and making sure that your patient understands what drugs they received, what treatments they received, and what side effects they could develop long term. But even more than that just intense discussion about their treatment, I think as far as survivorship care, I think we need to remember that we're treating that whole patient. It's so interesting when a patient gets transferred to my clinic and we start our conversation and we're talking about just general health. Just, so what's going on in your life? And I go through my scenario and I talk about family history. Has family history changed? Oh man, it certainly could have in the 3 years that they've been under oncology care that no one's even identified. Oh yeah, well my sister now has melanoma. Oh, okay. Well, that's a red flag for me. That could be a discussion with a genetic counselor. Have you had that colonoscopy yet? You were 48 when you were diagnosed. Now you're coming to me and you're 51. Has anybody talked to you about a colonoscopy? No. Well, guess what? We're going to get you set up for a baseline colonoscopy. And, is your skin changing? That family history of melanoma, have you ever seen a dermatologist? Nope. Well, guess what? We're going to send you to dermatology. So individualizing your care to just envelop that patient, because really I look at my role as more of a medical home. This is your medical home. I'm not going to treat all these things. I'm not a dermatologist. I'm not a cardiologist. I'm not a hematologist. I'm not an oncologist. I'm not, an endocrinologist. I'm not going to treat their thyroid disease. I'm not going to treat their blood pressure. But I know who to get them to. And I think that's the important part of survivorship care. Psychosocial issues. Maybe they've had a divorce during their treatment, and no one's addressed that with them. Maybe they haven't exercised in 3 years because they were afraid to lift their arm above their head. That's an issue. Pain. Maybe they have just pain syndromes from the treatment they had, from scarring from radiation or from the surgery, or the implants feel horrible. Fertility issues. A lot of our young patients, that should be talked about at day one. And that's a goal that we should all have. Weight gain, notorious. Breast cancer patients gain weight. Most cancer treatments, patients lose weight. Our patients gain weight. Maybe it's a hormonal issue. I don't know what happens, but they gain weight. And that's something we need to be cognizant of and help them with. Diagnosis of new recurrence or metastatic, and national recommendations include a treatment summary and survivorship care plan. And there's a lot to talk about in that realm. During the clinic visits, medical history and physical exam every 3 to 6 months for the first 3 years after their first treatment, and every 6 to 12 months for years 4 and 5, and every year thereafter. Healthcare maintenance, certainly bone and cardiovascular health, weight control and exercise. Monthly self-breast exam, again, that's controversial, but I told you kind of how I get around that. And updating their personal and family history of cancer. So recommended cancer screenings, post-treatment mammography, annual following the initial diagnosis, or if survivor received radiation therapy, wait 6 months after the last treatment because there's going to be some scarring issues. And mammogram every 6 to 12 months thereafter is really determined by their surgeon and that discussion between the surgeon and the patient. By the time patients get to me, we're usually at once a year. Pelvic examination, certainly recommend that your patients continue regular visits to primary care, including pelvic and pap smears for younger folks, and if a BRCA mutation is noted, certainly evaluating those ovaries. Inform the primary care about the potential risk of vaginal bleeding and increased risk of uterine cancer associated with tamoxifen. And I always put in my note, if a patient's on tamoxifen, watch for vaginal bleeding. Any bleeding that's after menopause is not normal, and that needs to be monitored. Other routines, cancer screening, talked a little bit about that with colonoscopy and skin cancer. There's really no necessary routine test in survivorship care as far as labs, tumor markers, or imaging per se. Testing is really indicated by clinical findings. So if a patient's been in a practice where a lot of scans have been done, that's a little challenging when they get to us. And certainly given the Affordable Health Care Act and the way insurance policies are changing, meaningful use and justification of funds and resources. So routine tumor markers and scans really are not recommended. We'll talk a little bit more about that. Mammography, lack of high-level evidence to support an impact on disease-free survival or overall survival. A study in JAMA in 2009. There's certainly ongoing controversy. Mammography, though, is still our gold standard for detecting low-risk disease. Observational studies suggest that the method of detection really does not influence survival. Decreased specificity and sensitivity in the irradiated breast. So there's a lot of different modalities that are available to our patients now, including tomosynthesis or three-dimensional breast imaging, ABIS or automated breast ultrasound, breast MRI, traditional ultrasound. So there's lots of different ways to get good pictures of breast tissue. Many survivors do not get a mammogram in the first year post-diagnosis. 62% of women in one series did not have a follow-up mammogram in the first year following diagnosis. And that's very interesting to me, certainly because that is the gold standard and that's how we're going to pick up a recurrence most likely. Cancer-focused tests not currently recommended by ASCO and asymptomatic survivors include CBC and chemistry profiles, chest x-rays, bone scans, livers ultrasounds, CT scan, PET scans, breast MRI unless they have a hereditary risk, and those tumor markers like CA15-3, 2729s, and CEAs. Now, I can tell you that if I'm following a patient in survivorship and they have had cytotoxic chemotherapy, or if they had a stage 2 to 3 breast cancer at diagnosis and received chemo, I'm going to get a CBC and a chemistry every year. That's just the way I practice. And I explain it to the patient if they're not seeing a primary doctor and they're not getting full, evaluation. I explain it like this. A CBC is a very good snapshot into what your bone marrow is telling me. And if your bone marrow is working appropriately, then you'll make good white blood cells, you'll have plenty of platelets, you'll make good hemoglobin. And that is a very simple tool that tells you, just in a snapshot, how that patient's doing. I also get a chemistry if they had positive nodes or received chemotherapy and have a higher risk of recurrence, because I, again, explain if you have an elevated calcium, that could be a red flag to me. If you have an elevated alkaline phosphatase, that could be a red flag for bone meds. If your liver functions are out of whack, or your bilirubin's up, or your kidney functions are abnormal, those are just red flags to me. It's a very simple test. It's low cost, but it yields a lot as far as information. So I don't traditionally get tumor markers and those kind of things. But if I have a patient who has a suspected recurrence or some new pain, you bet I'm going to use all the modalities I can to diagnose where they are. So detection of early recurrences, there's some controversy there, right? So how can we justify it, but what are the disadvantages? Certainly the justification is early detection results in more effective treatment, but does it affect overall survival? No. Patients are reassured. That's a justification, certainly. Peace of mind is important. But does it improve quality of life? The investigational endpoint, we really need to monitor the effectiveness of the adjuvant therapy. and get some good guidelines for whether detecting an early recurrence is beneficial. Certainly, disadvantages, aggressive screening results in overtreatment of early disease. And there's a lot of controversy now by healthcare in general about, how aggressive should we be with screening? How old should a patient be before we stop their mammograms or, pap smears or other tests? Routine testing creates anxiety and need for additional tests. I can tell you that some of our patients that have been under the care of physicians who do those types of tumor markers, screenings, and those kind of things, there's a lot of anxiety. I still have some of those patients in my practice, and of course I'm going to follow the guidelines from their collaborating physician. But I get phone calls like 24 hours after a CA 15-3. What's my tumor marker? Is it okay? It does create a lot of anxiety. And then what do you do if it's slightly elevated? Because it can be elevated for multiple reasons. Maybe they have a virus, and then you start, plunging into this black hole of trying to find out if they have a recurrence. So I can see for the patient, it really does add a lot of anxiety sometimes. And then there's increased cost to patients with possible benefit. COPE is the Quality Oncology Practice Initiative, and it's an ASCO benefit to ASCO members, and the Cancer Center at KU is COPE certified. And what that means is that there are quality indicators that we're required to meet to keep that certification. Patient emotional well-being assessed by the second visit, so some sort of documentation in your chart that says you've addressed that with the patients, and I think we do a good job with that. Infertility, certainly right off the bat. A young patient still has their ovaries, you're going to give them treatment. Do they ever want to have babies? That's a discussion you need to have with the patient. Palliative care and end of life, certainly we get to a point with some of our patients that that's a very appropriate conversation. And access to genetic counseling and testing, and then treatment summary process complete, getting that summary of the patient's therapy and treatment in a document for them. Within 3 months of chemotherapy end, and there's a lot of controversy on how to define that. The ASCO template for cancer treatment plan and summary, that's just one example of what's out there. That's available. Most of them are pretty cumbersome. I'm sure a lot of you are familiar with the Live Strong, the book, the book that takes hours to fill out. So survivorship across the continuum of care. Modified cancer care trajectory, we start at one point, and where do we go? Where do we go? And there's a lot of steps in between there. COC standards impacting the delivery of survivorship care, certainly monitoring, community outreach, clinical education, like what we're doing today, patient navigation processes, distress screening, and the care plan. Components of the care plan certainly should include the summary of the treatment, individual risk for late effects and second cancers, and long-term monitoring for late effects. And those are all things we've talked about today. Managing those consequences of cancer treatment, again, looking for those side effects and referring to the appropriate people. My patient is a whole. It's not just their breast cancer. I'm concerned about their psychosocial, their psychological, their social, did they lose their job, their spiritual health. It's all together. Practice guidelines, certainly listed there. These guidelines are designed to really provide a framework for general survivorship care, and it's not intended to provide specific guidelines. We just need to make sure that we cover what treatments the patient has had and what late effects are possible. EPIC is our O2 system at KU, and there is a form that is being developed. It's probably not going to roll out until 2015, but it's very cumbersome, and it's all self-manual input at this point. So we've worked around that, and that's what I showed you earlier with my clinic note. The delivery of survivorship care, it's multidisciplinary. It needs a team. We don't do this alone. We need our social workers, our psychologists, our therapists, our exercise specialists, our nutritionist. We need everybody on board. And creating those good sources for referrals is very, very important. There's a lot of barriers, certainly experience, and it's a cumbersome task, but how do we get it in there? And I think what's important is that you're committed. Certainly the standards are going to force us all to provide this care to our patients and a plan. And there's resources available to help train professionals to learn how to provide this to your patients. And I think we need to take advantage of those resources. Again, these are some of the things that our typical patient will walk in the door with. And there's lots of incredible things we can do to help patients get through these symptoms and manage them appropriately. Oops. Challenges, remember I was talking about very focused and targeted therapies. Estrogen positive breast cancer patients live a very long time. And so how long do we continue therapy, and what does that mean as far as their overall health? And I think those are certainly things that we need to think about. Now the guidelines are saying 10 years of tamoxifen is better than 5. So how are we going to make sure the patient's taking that for 10 years? I mean, we have trouble, monitoring that they're taking it for 5 years, but 10 years, that's a long time to have a daily drug. So again, patient-centered survivorship care, it takes the whole team, but remember your patient is part of that team too. Get them involved in the dialogue. My visits take about 30 to 40 minutes, and we talk about everything. And I want them to be informed, I want them to be educated, I want them to have power and know when to call us if there's a problem. So being cancer-free is not the same as being free of cancer. I think that's pretty profound. And I think we need to keep that in our minds and in the forefront. When I walk into a patient's room, I remember I have to pause and I say, okay, what has this patient gone through? Really? How has this changed her life or his life? I have some male patients too. How has it affected their relationships with their families? How has it affected her body image? Does she feel good? Is she afraid? Where can I be powerful and influential in just helping that person? And that's my focus. Before I walk in that door, that's what I think about. Okay, this is Nancy. She's got 2 kids. She's an 8-year survivor. She had a horrible mastectomy. She doesn't like her reconstruction results. She lost her job. She got a new one, thank goodness, but she's gained some weight because she was depressed. Those are the things that I want to concentrate on. So, there we are. Any questions?
You got a question? Put this in front of you.
I think it's problematic sometimes to get people to work together as a team and to get that information either to and back from other providers, like their primary care provider or their cardiologist or their OBGYN. How do you think that you guys are going to work with that?
Sorry, I'm trying to get everything.
I can talk pretty loud. I said I find the biggest challenge to be the emotional distress that our patients go through, and it's a challenge for me then to be able to. I'm an oncology nurse, but to be able to handle that, and I know it is for the physician I work with too. How do you, get other healthcare members on board with handling that emotional distress and anxiety?
And I think, you made a good point. The first item is that you recognize it, because I think some patients feel like they're alone and that their providers don't recognize it. I think the fact that you're aware of it is the first step. Then what do you do with that in your short, limited of exposure time with that patient? I think making sure that patient knows that there are good resources available. There are great support groups. There are wonderful organizations in Kansas City that they can use free of charge. There's wonderful classes they can take. I always try to just focus on what's the root of that anxiety. Tell me more about that. I know you're saying you're distressed and you're worried, but tell me more about that. Is it because you're worried that you're not going to get to your daughter's celebration? Or is it that you're worried that you're not going to talk or going to be here every day, 3 times a week, and you're on the cusp of losing your job? So I think getting to the root and then trying to find resources, because we're so fortunate in this area that we have so many good resources. Cancer Action and American Cancer Society and Turning Point and Faculty. And I mean, we just have a rich environment. What? Gilda's Club. Thank you. I love them. That red door. Yeah, we have suppliers in our clinic because that's important. We have a lot of thoracic areas that are terrified that they're going to get over this.
Lori, we have one more question.
Bye. Thanks.
I'm kind of jealous that we're not going to get the Halloween cookies, but thank you very much, Lori.
They're cupcakes. They're skeleton cupcakes.
Skeleton cup. Sorry. Okay, well, before I introduce our next speaker, I want to take you on a little tour of the center that she is the director of. This is the Breast Cancer Survivorship Center at the University of Kansas Cancer Center. And yes. And we're going to do it with just a very brief video because I could describe it, but why not take you through the miracles of technology? So here we go. Okay, Jennifer Klemp. Dr. Klemp is an associate professor of medicine in the Division of Clinical Oncology a cancer risk and genetic counselor, and the director of cancer survivorship at the University of Kansas Cancer Center. She's the founder and CEO of Cancer Survivorship Training, an online education company supporting healthcare professionals, and is the principal of Cancer Resource Partners, an organization providing consulting and resources to healthcare-related organizations and providers. She has published and presented work with a focus on cancer genetics, shared decision-making regarding options to manage cancer risk, the impact of lifestyle modification in cancer survivors, and the development of cancer survivorship programming. Ladies and gentlemen,
Thank
Dr.
you.
Klemp.
All right. Thank you, Bob. Appreciate it. And thank you all for being here this morning. I know a lot of you, so it's great to see you on a Saturday morning. I think the other important part in that video, you saw people who were not there anymore or they've moved on. So the good part is the Survivorship Clinic is continuing to evolve and continuing to grow, and that's a good thing. A couple of things Lori alluded to, and as the provider, one of my jobs is to make sure she can do her job. So one of your questions was about psychosocial support and so forth. So we'll talk a little bit about how we make sure that she has the resources she needs so that we can all work within our scope of practice. And I think that's really a key kind of focus of what we've tried to do lately, is how do we get you to work within your scope of practice, providing you with the resources you need. That's hard sometimes. It takes coordination, and sometimes I feel like it's like changing the culture. I think we all kind of feel that way sometimes. So we'll talk about some of those things today too. One of the things that is so key, and the other thing I'll allude to is we did change the slides up a little bit because I wanted Lori to talk a little bit more about focusing on clinical delivery. So we're going to email those out to you guys just to let you know that. But the survivorship care model is very similar to what you already know from diabetes or cardiovascular disease. These are chronic disease models, and if we focus on it that way, then it makes more sense. I think the first piece is not thinking we can do everything. We need our community partners. We need Gilda's. We need Cancer Action. We need Turning Point. We need all of the therapists that we use across the community, the physicians we use, Dr. Murray in primary care. I mean, we need a village. And if we don't know that village and we're not aware of that, then it limits how we get access to our patients. I think the other key piece is that the healthcare system is complicated. Just because we have Epic, you may have Epic, and if our patient goes to see your specialist, they're not going to be able to use that same information, as we all know. You scan it in, and then you can't find it. So this is a huge barrier. It's the story of our lives, right? And that's another reason why all of those templates should never be used. They should be an example of how we build that into our clinical notes, because anything you scan in, anything from the outside, you're not going to find it, and it's not going to be useful to you or your team. And then we have challenges, obviously, with the delivery system, because how do you get a patient to that cardio-oncologist? And what even is a cardio-oncologist? So that's another one of our jobs, is to help build that support. Lori mentioned fertility. One of the things that we start now with our nurse navigators is they do an intake. Part of what they do in that intake is they ask patients, all patients under 40, have you completed your family? So that's a gentle way of sort of getting to that question, and we can start and facilitate that process. Another question that they ask up front, which is good for me, is they start asking about family history, so that by the time they hit the door, I'm already seeing them. So I think the important part about what I need to provide to Lori and to our other team is glue. We've done that pretty well in breast. There's always room for improvement, but we also need to extend that out into the other disease states. I always get the question, well, there are other cancers besides breast. Well, of course, but I think the first thing is you have to start with a population that you know. You have to start with a population that also is a consumer that will eat that up. And as we know, breast cancer survivors are very active consumers, information, services, so forth. So I think they're a good population to work out. We then need proactive providers and empowered and proactive patients. This is challenging. We work in silos, and I find it's somewhat interesting that for years we've been trying to get primary care out of oncology. Have you been working on this as well? We are their doctor. They'll call us year 7 because they sprained their ankle on the sidewalk and they want us to do an x-ray. That's all good and fine. We answer the phone, we call them back, but that's not okay. We need to have a shared care model. Dr. Murray will talk about that, and it's so important to have that relationship. The other piece of that is that a lot of these providers don't feel comfortable. They're not necessarily, it's not that they don't know how to care for cancer survivors, because trust me, they have them in their practice, but where's the permission? Is it okay for them to order the colonoscopy? And I'll show you some data here in a few minutes. And this is really part of the reason why we started the online learning platform, is how do we train an entire system? So I'll give you an example from Hays, Kansas here in a minute, and talk to you about how we've done quality improvement in that environment. So this is just a snapshot of what survivorship care can look like from the time of diagnosis. And if we use the definition that a survivor is from the time of diagnosis, then survivorship care can be an umbrella, and that continuity clinic that Lori talked about is part of survivorship care. It's a survivorship care clinic. But the entire process of survivorship really, I think, makes us be the glue that can pull all those pieces together. So whether it be fertility preservation, and when we first started, our survivorship coordinator, who was Anna at the time, and then Katie, those two women were the ones who facilitated those referrals at first. Now it's part of a process. So if we can help with that process, then it makes that a lot more efficient. Obviously, lifestyle consults. And this has been an interesting transition, because if you think about nutrition traditionally in oncology, it's not to help people lose weight. It's to help people obviously have sustenance so that they're not wasting. So in breast, in GYN cancers, that's a different paradigm. We really need to help patients obviously lose weight. So now one of the things that we try to educate patients on is that during treatment, we want them to stay weight neutral. We don't want them to actively be losing weight, but we actually use the word sort of weight neutral. And then 3 months after they complete treatment, we encourage them to begin a weight loss program. And we'll show you some data, and then Danielle will follow up on that as well. And then obviously focusing on other aspects. And I think we do help facilitate also access to clinical trials. I know we have some of our clinical trial folks here as well. We learn from them, and we need them to help us. But could we be a reinforcer, obviously, to help identify and get patients in for participation in clinical trials? And then lastly, when I started doing cancer genetics in 1997, it was primarily very limited. Maybe the oncologist referred. Now 95% of my business is with the surgeons. So we do all of our testing as much as we can up front, so you have that information for treatment planning. And that is a very important part of their survivorship, because if we can't do that up front, they're going back for more surgeries, they have more risk, and that doesn't work so well. Then if you look at post-treatment, it pretty much looks the same. So that's what I want to reinforce to you, is that all these types of services are really the same, but it's how they access them and what they need across their cancer journey. So one thing I wanted to highlight, just based on kind of my practice, is a new piece that's come out from ASCO just this year. Excuse me, some water. Thanks. And do you guys ever look through JCO or get any excerpts from that? This was from spring, and one of the things that Dr. Hudis talks about is the importance of genetics in everything we do in oncology. So I've built a program actually for our nurses, and if you haven't got it yet, it's going to be coming to you. It's on genetics and genomics, because like Lori mentioned, everything we do for patients now is so biomarker driven. And did any of us really have biomarker training in any of our training programs? Very little, if any. In our current curriculum, I've gone and scoured our nursing curriculum. There's an hour of genetics, and then maybe you get a little bit in sort of clinicals, and then a tiny bit's embedded into surgery and internal medicine. That's kind of not okay when everything, I don't care if you're in cardiology, cancer, you name it, is based now off genetic and genomic tests. Cardiovascular genetic testing is a growing, booming market. And so it's important for us to have this comfort, and it doesn't mean we all need to be experts, but we need to know what our role is in that. This is some data from that COPE certification, and what it talks about is we do a pretty good job collecting at least first-degree relatives. But what are we supposed to be collecting? A 3-generation pedigree. Now that's a labor-intensive work of love, and so what we just finished putting together is a 1-pager. For those of you at KU who haven't seen it, you will. It's very easy. It's something we can also give to our patients every time they come in, because it's a nice 1-page check sheet that gives you the information you need. It also prompts them to get the date of onset. That's a very important piece, because maybe we want to know if it was a 92-year-old grandma with breast cancer versus a 42, that makes a big difference. But we don't do a good job with that. Here's why that's important. And this is your survivorship issue in genetics is that if you aren't identifying these patients up front, you're only going to have more and more and more patients over time. Overall, we are only identifying about less than 40% of eligible patients to date for cancer genetic testing. And we do a decent job in breast, I guess, but it's not even 50% of eligible patients. All ovarian cancer patients qualify. Now, I may not want to test the 92-year-old with no other family history, but Medicare will pay for any ovarian cancer to be tested, any male breast cancer. We aren't doing this, and look at the number of ovarians being tested, less than 24%. This is important because it also gives them access to PARP inhibitors and different types of trials and treatments. We also, if you saw JCO just last week, a new study in pancreatic cancer and access to PARP inhibitors if they're a BRCA2 carrier. So this is important not just for breast, but obviously across the board, but we have a lot of work to do, and I'm so happy that that is part of our follow-up now in asking those questions, because we have another percentage positive, which I'll show you in a minute, just from our survivorship clinic. So as you know, we are a modern family, and some of you are here from MCA or Midwest Cancer Alliance partners, and thank you guys for coming. And we actually have worked with Dr. O'Day and Nicole Spray out in Hayes, and they have a prevention and survivorship clinic out in Hayes. They do much of the same stuff we have. We've been helping them build that network of partners as well. And just to give you some examples, they've increased their identification and testing for genetics by over 1,000%. That's crazy. That's because nothing was happening, and now something's happening. And one of the things we're working on with Salina is that they go ahead and they pull from their tumor registry every triple negative under 60, every breast under 50. They're pulling those patients in their population, and they're seeing who they actually tested and who they didn't. Kind of important, because if you're a gene carrier, you have a 65% chance of another primary. And if we don't know they're a gene carrier, then they're in our practice, or maybe we send them back to primary care, and we don't know that risk. So I think it's important to be respectful of the fact that, yes, I come from an academic center, but we do have our community practices as well and the rules setting. And so I think we have a great opportunity to work together to try to figure out how to translate survivorship care into each of these settings. It's unique. It's unique to the champions you have. It's unique to the practice. So we have to be a team to really get this to work well. The unfortunate part about the National Cancer Institute's trajectory is that they put survivorship at the end. And I think that does a disservice, because then we're always trying to play catch up to get survivorship care earlier on in care. And I think this was a struggle that we did at first, where we said, okay, fine, we'll be at this end of treatment. But now we're really trying to be part of distress screening, to be part of that fertility discussion. And our first collaboration was with cardio-oncology in 2006. We didn't have a cardio-oncologist, we built a cardio-oncologist. And we now have 3. And that's important, because if we don't have that partner, it's an issue for treatment, because think about some of the patients that you either dose reduce or discontinue their therapy. Cardiovascular issues, maybe it's a drop in ejection fraction, maybe they're symptomatic. But if we have an aggressive partner up front, that's helpful. And on the back end, we know that our patients obviously need screening. And one of the things that we started looking at was, what are the risk factors in our patients? And I should have put this in, but maybe in the slide deck going out, we'll add some new slides. But one was on some cardio-oncology data we presented at ASCO Breast last year. And one of the things we wanted to look at was, number one, how many of our patients were already seeing a cardiologist? Number two, how many risk factors using Framingham, and then also what we did to them. Left chest radiation, any type of anti-hormonal therapy. There's clotting issues, there's other things. Did they get an anthracycline? Were they on Herceptin? So looking at the traditional and cancer-related risk factors, we started collecting those, and we have a big REDCap database that we collect. And what we found is our average number of risk factors was almost 4 risk factors in women who on average were 58 years old. That's a lot of risk factors. And how many of those patients had a cardiologist? Not quite 20%. The others were maybe being seen in primary care, maybe weren't, so that's another one of our priorities, is getting them a primary care physician. But what we decided to do was, any woman who had 4 or more risk factors, get them into our cardio-oncology screening program. So if any of you know Christy Russell and Jill Keast, they're amazing oncology or cardiology nurse practitioners. They see our patients for screening under the direction of Charlie Porter and Brian Wyford. So by doing that, we were able to see, what do we really need to do with these patients? Some of the patients actually needed stuff done. Some of them were symptomatic, some were asymptomatic, and that's a majority of our survivors, asymptomatic, living with risk they don't even know. So I think that that's sort of a take home, is that we need to be identifying that up front. Carol Fabian and I sit along with Charlie Porter on a NCI task force on cardio-oncology. And one of the reasons for that task force is to figure out how do we get information up front earlier, because you know those people who are already at risk when they walk in your door. Are we identifying them appropriately? Do we need to be doing other blood tests, troponins or BMPs or whatever? So I think it's important to know we need to do stuff up front, we need to do stuff on the back end, and 92% of our patients that we referred to the cardio-oncology screening clinic went. That's a high number to actually show at that visit. And then we looked at what happened to them. So I had these med students, because as you know, there's no feedback loops in these electronic health records. We need registry features so we know if people went and what happened, and that's coming. But we had the health of the public students look this up, and we found that a lot of the patients were then referred back to their primary care physician, but the primary care physician had a note and a recipe from the cardiologist. Some of them were going to come back because they had medication changes. Some needed imaging, and some needed actual interventions. We had a couple patients who needed stents and so forth, totally asymptomatic, off the grid. So I think it's just an important piece to think about. If you're from a hospital system, yes, we want to be mindful of resources. The Affordable Care Act really promotes that. But at the same time, do we have patients that would benefit? And when you're building a program and from a hospital, building things that can stay within your system obviously are attractive to that program development. So really think about how do we care for patients? How do we work across the aisle to our specialist friends and make that work? So this is kind of how we started. We wanted to really do a stepwise process in 2006 to start building those resources and kind of building more gender specific. So breast cancer patients allowed us to build kind of a women's health service line, and then our prostate cancer prevention survivorship clinic is helping us build our male service line. But as you can see, it really encompasses that whole person, things from the time of diagnosis and into long-term extended survivorship. So here's some data that we presented at the San Antonio Breast Cancer Symposium, and through support from Back in the Swing, we've been able to have a survivorship coordinator and navigator to help collect this data and really allow us to bring this information kind of to the forefront. And as you can expect, we were naturally risk stratifying who was referred to Lori's clinic. It makes sense. You're going to take lower risk patients and refer them to a survivorship clinic. Higher risk patients stay in that acute setting a little longer. But they don't have to. So now we actually have triple negatives who are 3 years out who are seen in survivorship. But in the initial stages, women were about 5 years out, 58 years old at that time, earlier stage disease, and we had a lot of younger patients just based on the population we see at KU. And as we started looking at some of the other factors, weight gain of about 5 pounds in 5 years. Well, you may not think that's too bad, but I'll show you some other data in a few minutes. But if we looked at women under 40, there was actually over a 17-pound weight gain in those youngest women, which we know weight gain has lots of risks. Risk of reoccurrence, risk of diabetes, risk of heart disease, risk of death. So are we focusing and educating patients up front so we can help mitigate some of that on the back end? And we always lie, and Danielle will kind of attest to this about minutes of exercise, so we don't even look at that anymore. We need better tools. So then we started looking at menopausal symptoms. So one of the other things that we've done, because when you have a survivorship clinic, and especially if you're using advanced practice providers to run those clinics, you need trust with your providers. So one of the things that we do is we build a snapshot, we take it to those providers, and we really sit down with them so we can provide physician-directed care, but still have it be in our survivorship clinic. So that meant we had to have pathways for menopausal symptom management. So when we saw these values up front, we're like, wow, that's kind of pathetic because we actually have pathways, whether it be medications, whether it be over-the-counter, prescriptions, you name it. And we have partners in GYN that help us. So why are some of these numbers the way they are? The biggest one we didn't like was 46% not being sexually active. And the comparison we used was one of my partners, Dr. Kumar Khan, had a vitamin D study. And when patients started on that study, we actually asked about if they were sexually active because it was part of one of their questionnaires. And at that time, it was less than 30% actually reported being not sexually active. So, over their survivorship period, now we're at 46%. So we decided we would start asking that in follow-up. So as part of our intake, we ask about menopausal symptoms and about sexual activity. And now we ask them, is this a priority for you? Do you want to work on this? Because some patients absolutely don't want to go near that. And it's not okay for us to say, well, we want to fix that for you, when that's not an issue they want to fix. Some of these other things have, physical symptoms and so forth, but it needs to have that patient-centered focus, because if not, then we're not listening to our patients and we're not managing them appropriately. We did pretty good with bone densities because we had a lot of women on anti-hormonal therapies, but we also said, should we be incorporating our primary care partners in ordering that? There's no reason they can't. Some of them even have bone densities in their offices, so how do we push that onto them? And we'll talk about that in a second. But what we did find is that a lot of our patients were absolutely not getting well-woman checks. They weren't getting colonoscopies. They weren't getting things. They were in our note, but those things weren't happening. So we decided to do a follow-up this past year, before Katie left, if any of you know Katie, which has been a devastation to me. And so when we looked at the data in follow-up, what we found was some things we really improved on. So one thing, we identified 10 new primaries in the survivorship clinic. 45 of our a little less than 425 patients had a second primary. That's a lot of patients. A lot of them were skin, but we also had, in the 10 new, asymptomatic lung. The first patient that was our take-home message about colonoscopy, 62-year-old that had never had a colonoscopy, diagnosed with a rectal cancer. So those are teachable moments that are like, what do we want to do about that? So we decided to take on, just like Lori said, we actually schedule that colonoscopy for them. We had a 77% show rate now by taking on that responsibility as a cancer care team. What is it before? If you look at a specialist and a primary care both telling a patient to get that and not scheduling it for them, it's about a 21 to 25% show rate. So by us taking that on, we now have patients getting that service. And if you think about it from a cost perspective, there's a lot of cost by not having a colonoscopy. There's a lot of reduction in cost by having that. So I think the other thing I would challenge you with is, what do you want to be responsible for? And that's really what we've tried to delineate in our notes is, okay, we will do cancer screening, we will see you on this frequency, but we want to push to Dr. Murray or to our primary care partners what they need to be doing. And that's an important piece, because if we give them permission, now it's actually happening. Before, just because it's in the note, it's sort of like no man's land. Well, who's going to do it? Who's responsible? And nobody wants to overstep the other boundaries. So our primary care partners, they don't get mad that we tell them, this is us, this is you. So people worry, well, they're going to get mad if we tell them. No, they don't. So I think that that's an important piece. And then we started looking at, well, what were these patients? What were they doing? Why were they not using things? And we found there's a lot of compliance issues, and some of the patients didn't want to deal with it. So this is also important, because just because we see a problem, we need to understand what that problem means. So for vaginal dryness and hot flashes, which I'll tell you about 30 to 40% of every visit deals with menopausal symptoms, because patients are really miserable, and a lot of them are endocrine positive and can't take anything. So this is an active, ongoing sort of challenge. We did a great job with bone densities of our patients who needed to have a bone density. We actually had 100% of our patients getting that, which is awesome. And I think the other important piece is that now we need to work on some of these as a shared care relationship so that this can be done by primary care. So let's go now to kind of lifestyle and these teachable moments of cancer. And I really do think that the pivotal moment of a diagnosis is an opportunity all along the cancer journey to reinforce what a patient needs to be doing with movement, with nutrition, and really having a guide like your Back in the Swing cookbook to give to a patient to really help them understand what their issues are and how to resolve those. ASCO just put out some great resources this summer. If you haven't seen them, you don't have to be an ASCO member. You can just click on their website, but it's worth going on because it really talks about how this needs to be part of our practice. It's also important to remember there are lots of guidelines out there. And when you look at this guideline, this is from the American Cancer Society and the AICR. And so if you look at this, be as lean as possible, balance your caloric intake with activity, avoid excess weight gain throughout your life, consume a healthy, mainly whole food type diet, limit alcohol. These are any different than general guidelines for average people? No, of course not. So the same guidelines we should give to our cancer patients are the same guidelines we should be following as non-cancer patients. But there is a challenge to that, because cancer survivors are a special population. Maybe they had a lymph node dissection. Maybe they've been sedentary for 30 years and now we want them to exercise. Danielle has these people in her studies. One of the studies she'll talk about is decreasing sedentary behavior. You know, I think one of the fascinating phenomenons we found in one of our first studies is that women would hit their minutes of exercise a week, which we'd recommend 225, but the rest of the day they were more sedentary. So they were like, they worked hard and then they chilled out. So that's not okay. How do we keep you moving all day long? There are lots of guidelines out there, but how do we put them into practice? The American College of Sports Medicine also has sort of the support of this, and they did a big sort of meta-analysis where I know you guys have seen where it's really labor intensive, but they go through all these things and give you the level of evidence, so level 1, level 2. So they went through that with movement and really adopting a physically active lifestyle. So we should be telling our patients from the time they're diagnosed, you know, stay weight neutral today, but we want you to lose weight, give them an expectation, and what were you doing before? So if you have somebody who's exercising 3 or 4 times a week, we don't want them to stop that. We want them to continue that. Maybe they need to modify it, and what we found early on is to give them permission. Say, hey, days you don't feel well, days you're really kind of nauseous, tired, just take it easy, but the next day get out. And so we have people like Sammy out in our community practices who can also meet with patients real time. This is nice because then you're reinforcing that. They feel safe, they feel comfortable. But it's not okay not to tell them to keep moving because we also know there's a lot of changes that happen very rapidly where they lose lean muscle, they gain fat, and those are risk factors to our patients. And strength training. One of the first studies we did looked at cardiovascular risk factors and used what were called power blocks, which are these little toaster type devices that you can use as weight at home. And we know that especially getting patients on a supervised program where they feel comfortable and getting them back out into the Y or wherever they at home where they like to exercise is important, but we need to make sure they do it safely. So it's low and slow. You start low weights, you start slow, and Sammy's actually worked on some great stuff for us to give to our patients as well. So the term energy balance, I think, is really is not as it seems. Energy in isn't energy out. So we have some patients where, you know how on your treadmill, if you have like your heart rate monitor and it tells you how many calories you burned. So we'll say, well, I had one patient who said, well, I drank 110 calories of wine and then I was on the treadmill and burned off 110 calories. And I'm like, it's not even, Stephen. These are not equal calories. I wish they were, but they're not the same calories. And you have a lot of other features that are happening. Metabolism, how our body works, hormones. And with a lot of the changes that our cancer patients go through, their hormonal milieu is all whacked out. And sometimes it's really hard to get back on. Then we throw an aromatase inhibitor on top of it. This is a complicated hormonal system, and it really does impact their metabolism. But becoming physically fit and moving also helps with some of their symptoms from the aromatase inhibitors, in particular arthralgia. We find that initially patients, they don't like to exercise sort of at first because it hurts, but once they get through that, it actually has been shown in multiple studies, including one by Melinda Irwin published last year, that it actually improves the arthralgia. So how are we getting them moving instead of reinforcing, oh, just take it easy, it's okay, because it's not okay. We always use BMI, and I know we all kind of hate BMI because our patients hate BMI. And what's the biggest thing that people don't like to be told, and it's in their note? This obese patient. Well, that's a medical term, but the patient hates it. We put it in there because we bill for it. It's a modifier, right? So how do we explain that to the patient? Because what we do clinically, they don't like necessarily to hear that term. But a lot of our patients are obese. They're not just overweight, they're obese. And this is a problem for a variety of reasons, but the BMI does have a historical, obviously, history of being able to calculate what our risk for dying is, right? Lots of causes, cardiovascular disease, cancer, and it's a good benchmark so that we have that as a comparison going forward. This also is the US trend, which I think, you know, one of the nice things, what are we seeing with the overweight? Kind of tapering off and actually going down. So those who I like to call us sort of soft, you know, the soft population is kind of staying and tapering off, but obesity is still on the rise. So those who are really overweight still are increasing. If I showed you how cancer overlaps with this, it's interesting because when you look at risk factors for breast cancer, we know that being a gene carrier is your highest risk, but obesity and being overweight becomes a very important risk factor because it's so prevalent amongst the people. Gene carriers are very rare, just a handful. But when you have, you know, 68% of our patients coming in overweight or obese, that becomes a bigger public health issue. So that number is huge. So from a population standpoint, even though the risk is only 2 or 3-fold increase, it's so many of our patients. So that's why it has to become part of our practice and part of our workflow. This is a J-curve that we actually show in our diet and exercise studies. And the first time we showed this, which was back in like 2005, I was worried about showing a patient a J-curve showing them that the higher their BMI, the higher their chance of reoccurrence and death from breast cancer. Because you don't want a patient to feel guilty about that. You don't want them to say, dang, I caused this. Because we all know that there's multiple risk factors that go into cancer. It's not one thing, it's a multitude of things. But this does show, and if I showed you the diabetes curve, they're all the same. As the BMI goes up, the disease rate goes up, as does the mortality rate. So important to understand why that BMI curve is important to our patients. It's also important to know, once again, how does that look when patients go through their cancer journey and the weight gain. We know that on average it's about a 2 to 15 pound weight change in the first year alone. And I can tell you that we have an iBook on energy balance that we use for our patients. And one of the nurses that we work with on that, she was actually helping us deliver this iBook. And lo and behold, and she'll tell you, she was diagnosed with breast cancer. She said, I knew everything in your book, and I could not stop the weight gain. Young woman, had little kids at home, working full time, triple negative breast cancer. I mean, it's the kind of patient you see all the time. We need to be able to help her achieve those goals. I think the hardest part is that our patients are complicated. They don't have just one issue. They have lots of things that they need to keep balls in the air. And so I think it's really important for us to be able to be mindful, because we all may know what's right, but how do we act on that? Behavior change is so hard, and especially when there's another life issue going on. And we know a lot of our patients have what's called sarcopenic weight gain. And I always think about it when you go to any like pink race or pink activity, you see women in pink shirts that have kind of this softness across the belly area. That's sarcopenic weight gain. They may not have had that before, but now they're really soft, because very rapidly they gain fat and lose lean muscle quickly. Happens 3 to 6 months. And that sarcopenic weight gain is fat, and fat produces hormones. And I think my next slide, no, it'll show you. I'll get to that in a second. But basically, that adipose tissue produces lots of different things that can cause risk. And it's hard to lose. Once you get that, it's worse than normal weight loss, just because of all the changes that have happened metabolically. So here's some data just kind of showing you that risk of really cancer death, breast cancer death, as the weight goes up. So as you can see, there's the benchmark, and then there's almost a 1.5-fold increase in risk. So about a 30% chance of dying from breast cancer based on just that weight factor alone. That's a pretty big number, and it's a number we can hopefully modify. This is also showing you physical activity prior to the diagnosis and post, looking at different stages, so early stage, stage 1, and stage 2 and 3. So what you're seeing is a huge decrease in activity based on just that first year from being diagnosed to a year out. And that's not okay, because we need to be modifying that, and we need to keep those levels up. So how do we put all these pieces together? Diet, which Danielle will talk to you quite a bit more about, exercise, and really focusing on our risk, which is cancer reduction. So this is a complicated slide. Melinda Irwin put this together from Yale, really looking at the balance of all of these factors. And as you can see, there's a lot of factors that go into risk that really, I think, have to do with weight, hormones, adipose tissue, you name it, all the complicated things happening in our body. So if you look at the immune function, and Dr. Murray will be talking a lot about, how do you be the best you can be in regards to your immune function. Inflammation, which we want obviously to decrease, and everything increases inflammation, right? Stress, food, you name it. Changes in our sex hormone, body fat, insulin, the insulin growth factors, and then obviously the adipokines, and those are kind of on a weight loss spectrum, so we actually look at those as measures in our weight loss studies. But this is a complicated picture, but there's still some common elements, like losing weight, like moving, that can really be helpful in all of these factors, and obviously reducing stress. So here was a study done, it's called the NEWS study, and this was not in breast cancer survivors, but it was in a population of women looking at, well, what's the best way to get to those goals? Is it to diet? Is it diet plus exercise? Is it exercise alone? And then unfortunately, they always have a control group. So as you can see, the diet group and the diet and exercise group are the bottom two, so they had the biggest weight loss. The other two, exercise alone, and control group, not so much. So what would you conclude by this? Do we need to encourage our patients to exercise? Yes. You don't have to, right? Because look at, well, Do we really have to? Yes. And the reason is a variety of things, which we'll talk about. But first off, you're never going to maintain that weight loss unless you're exercising. We know that you get very reinforced. Think about some of the low-carb, paleo diets. People lose weight fast, right? It doesn't matter if they're exercising or not. But if you want to maintain that level of weight loss and you're not exercising, it's really, really hard to do that. And you're not really getting healthier in the bigger picture. You are losing some of the risk based on insulin and estradiol, which is important. So we know that the weight loss is what really drives that. We've done some studies where we were looking at, and multiple studies have been looking at just exercise alone. Really hard to change a lot of these hormones, hard to change insulin just by exercise alone. You have to have the weight loss with it. So they really are Siamese twins. They have to be together and they need to be attached at all times. But the estradiol levels decreased both for the diet alone and diet and exercise, as did the insulin, and pretty significant insulin changes. So this is that question. I think that for early reinforcement, obviously focusing on weight loss is huge, but you need to couple it with getting people moving. A lot of our patients have been sedentary for a long time. So how do you get them moving safely? How do you get them into some classes? How do you have them meet with folks? And one of the things that we've been working on is one of our friends at the Y. She's cancer certified as an exercise trainer, as a SAMI, but we've also been working with the Y to get more of their trainers cancer certified. So now they are actually a train the trainer, because one of our goals is that you want the patient to go close to home. You want them to be able to go someplace that's safe. And why do we not refer to some people? Because we don't know if they know how to care for our patient who's had that lymph node dissection. SAMI had to go through extra training. Folks have to go through extra training to be able to do that. So we want to have a team out there where our patients can get access to that. So that's a really important partnership. And there's other benefits, obviously, to physical activity. So as you see, even though it looks like that fatigue bar goes up, higher numbers mean better function. So fatigue, depression, overall quality of life, all of those factors increase as weight and BMI and fat decrease. So that's a wonderful side effect with quality of life, and really should be written as a prescription, right on your prescription pad. You know, the first week, if you have a sedentary patient, you want them to maybe just get moving. Go one day, get out there for 15 minutes. But we need to help them understand that this isn't an option, it's really a prescription. There are some data out there, obviously, from the American College of Sports Medicine. I mentioned to you they've done this large study looking at what's really of value to our patients based on the literature. But this is the minimum kind of standard. And look at what you need to lose weight, right? You need to increase obviously your minutes of exercise, and to maintain 250 minutes a week. That's a lot for a lot of patients who haven't been doing anything. So that's where this exercise piece not only is important for all of the benefits it provides, but also helps us maintain those goals that we've worked so hard to achieve. So I think in summary, one of the things we really need to think about with this lifestyle picture is that diet and exercise need to be a prescription for our patients. They need to understand how to do this. They need tools. They need resources. And we don't have a lot of time to do that in our clinic. Some people are looking at, could we use our nurses and some of our symptom management tools to help identify this? How do we better do this? But it's not easy, and really we're not trained to do it in the clinic. So we need easy tools to be able to refer our patients to those resources. Because if you think about, once again, scope of practice, I think our job is to identify patients, get them to the resource, and then we need to use our teammates out there to really do a shared care model with our patients. Patients do need this incorporated into their survivorship care plan. They need the tools, and we need to think about survivorship care really as the glue that's pulling together all the things our patients need so they don't feel lost, so that we can use navigation appropriately, which is to really get patients where they need to get to, and use that risk stratification piece to get the right patients there. Every patient doesn't need everything, and we can't think about that. We can't think that every patient needs to go through the cafeteria line and get every single thing. That's not okay. It's not a good use of resources, and patients don't need those services. So we need to be mindful of how to risk stratify the patient so they get what they need, and we use our services appropriately. So I will stop there, see if you guys have any questions, and then I think you have a little break after that, is it right? To get some coffee and a snack.
That's right, but we do have time for questions. So, anyone?
There's one in the back. Oh, the Royals. Not Royals. There you go.
Wait.
The Royal shirt. It's only Royal shirt.
I have to get my movement. I'm going to get at least 20 steps out of this.
Do you have enough history with the paleo or gluten-free diets to see what the results are with those?
So Danielle will talk about that a bit more. She's more focused, well, now she will. But there was a study, what was it in? I think it was in JAMA, Journal of American Medical Association, and it compared Weight Watchers to South Beach Atkins. It compared 4 different diets, and really at the end of the year, what were the results? And interestingly, if patients really participated in each of those, they were about the same at 1 year. So I think for a success rate for weight loss, they were all about the same at a year because of the ebb and flow. How that relates to cancer, not really sure. There's been one study where breast cancer survivors had access to a Weight Watchers at the cancer center, which I think not a bad idea, but we just refer them to Weight Watchers in the community. But we're also working on kind of a fee for service at the cancer center where we would have ongoing access to that. So we can look at some of those questions. Because patients don't want to all do the same diet. We use a lot of prepackaged meals. We use a lot of portion control to train them. But how do we help them meet their goals with whatever type of diet fits best for them and where they feel good? Because some people feel better on different types of diets, obviously. Yeah.
Just a quick clarification on who gets referred to your clinic. I'm at the KU Cancer Center Overland Park location.
Yes.
So our patients could come to you?
Your patients could, but what we are doing is we built a train the trainer program for the nurse practitioners. So I am a huge believer that you need to get care point of service. You shouldn't have to go to a mothership or go someplace else. So that train the trainer is rolling out. Partially, that care plan initiative by the COC has a rollout over 5 years. So you want to have 10% of all your breast cancer patients. You kind of want to have that process in place during 15. So we will be rolling that out starting kind of late fall, early winter to the rest of the practice. Some of the practices are already doing that, the North Office and the South Office, but we need to, and from our perspective at KU, to roll that out. And then the bigger goal is to use that Train the Trainer program, not just at KU, but obviously to share that amongst the community. This is not something that's hospital dependent. This is patient dependent. So we will be disseminating that out. But that's a good question. Thanks.
I never really like these things, but do you, whether it's an in-house program or you outsource like to the Y, is there any research studies that are going on since diet and exercise, or particularly exercise, that have proved research, for exercise and the benefits?
Oh, there's multiple studies on
that
exercise.
you guys
yes.
are.
And one of the things I'll show you, because I've highlighted this, because some of you work in general settings, you're not just in cancer, right? So let me show you here too, because I would encourage you. How do I get to my, will you get me to the internet? Yeah, hold on one second. Oh, there we go. Yes. A lot of them are in-house. Some are going to be bigger. Yeah, we're writing an R21 that's a larger study. It'll be a SWOG study. We're writing a grant with the Y as well. And then the energy balance course we have on cancer survivorship training is excellent at showing you also a lot of evidence on breast, but the biggest risk for weight and exercise is which cancer? GYN. So, we're working in lots of different fields, so we need a similar message for our patients, but we need to know the kind of data behind that. So this gives you a lot of that and gives you kind of things you can download as well. But I think the key is there is a lot of data supporting diet, supporting exercise, and the hardest part is we don't have the data to say how can we get patients to actually do it and keep doing it. Yeah. So some of our studies were looking at long-term follow-up, and from our first diet and exercise study we did in 2005 to 7, and Sammy worked with us on that too. It was funded by Back in the Swing. That study, we looked at patients a year out, and about 35% of them still had that initial weight loss of at least 8 to 10% is kind of what we target, but then that just keeps chipping away. So, and that's not okay. I mean, it's hard. It's like smoking cessation. Weight control and smoking cessation are the same. You got to try again. And we need good resources for people both at the cancer center, but it needs to be close to home. We need to teach them how to do this stuff at home. Yeah, great.
Okay, we have another question, but just a quick housekeeping thing. Coming down the line here will be a little form. If you want the new slides from Dr. Klim's presentation and also the new slides from Lori Rinaldo's presentation, just fill it out, put your email on there. You don't have to check any of the boxes on the right side. But we need your email, and those.
And the other thing we can do is I'll attach some of those things from like last year and this year. We presented data at ASCO Breast with our support from Back in the Swing. And so I want you guys to see that, because that's really translation into the next step. We're trying to figure out how to take what we're doing, see how it works, and then translate that out.
I was curious, one thing that stood out to me on the slides was the significant difference between the weight gain of those under 40
Right.
and then those over. Is it also taken into account, I mean, that is a critical time, I think, for
Critical.
women too, gaining weight
Yes.
after 40.
Right.
Speaking from personal history.
I'm right there with you. I understand.
But so did any of the studies take that into account, what naturally occurs?
Sure. So we did do that, not necessarily in a weight loss study. We did that in a cognition study. So my dissertation long ago was on cognitive function in premenopausal women before, during, after treatment, and we just did 10-year follow-up. So we're going to publish that. And the interesting part is that we saw the same thing, because I'm monitoring. I did their hormone levels. I of course had weight. So we have this anecdotal data, if you will. And I think the interesting part is what we found in that study is you can't always tease out what's naturally happening versus what's not. And you have a constellation happening. You couldn't tease out menopausal status, because after the second cycle, every patient went to postmenopausal hormone levels with estradiol and FSH and the supporting hormones. Then you have depression, all of them, there was a little ping on that, fatigue, you have all these things happening. So then you're like, well, what's causing the weight gain? Is it the treatment? Is it fatigue? Is it they're not moving? Is it they're going through menopause? And I don't think you're going to tease those things out. So just call the constellation what it is, but we have the same recipe for it. And that's why it's so important to keep women weight neutral through their treatment. You don't want them losing weight actively, because you got all these other things going on, but we need to focus on them not gaining weight. So that should be a flag in our chart too. We have a flag if they lose a certain amount of pounds between visits. We should have a flag if they gain a certain amount of pounds, because they are. Yeah. One of the patients I'm thinking of right now, she had 32-pound weight gain in 6 months. You've seen these patients. These aren't, that's not okay. So, yeah, it's a constellation though. So, well, thank you guys for your time. I'll be around and you can have some snacks.
Thank you, Dr. Klemp.
Yep.
Dr. Klemp, you will be happy to know that just this morning, excuse me, I'm looking at my Back in the Swing limited edition pedometer, 2,427 steps. And you will all get a gift of a Back in the Swing pedometer from the Back in the Swing table back there. And so put it on today, because you're going to get steps, I understand, a little later. So we're going to have a break now, and you can take these little forms with your names and email. Just give them to our Back in the Swing volunteers at the back, and they'll make sure you get these 2 sets of slides that you don't have yet. Plus, okay. Well, we have another announcement, and that is... and this, by the way, is also for your patients and you, and get these handouts in the back, and you can also find out about this on the Back in the Swing website. I have a PDF you can download. It's a town hall meeting on breast cancer survivorship, and it's going to be sponsored by Back in the Swing, Living Beyond Breast Cancer in the University of Kansas Cancer Center, and it's also sponsored by Silpata, which is terrific. And it's going to be called Survivorship 360, Navigating Your Way Through the Redesigned Breast Cancer Roadmap. And the discussion will be a lot about what you've heard today, but it will be translated for patients, for breast cancer survivors, who will be able to listen to this from the comfort of their home, wherever they live in the United States. It's going to be streamed live, and I'm sure it'll be on our website and Living Beyond Breast Cancer's website. But there's limited seating for this beautiful space at the Cancer Center called the Atrium. And so there are phone numbers and email addresses on here that you will get if you want to attend, or you know some folks you think should attend or would like to attend. Please help us disseminate the information on this. And now a break. And it will be a healthy one, I promise, from the Back of the Swing cookbook. You will enjoy coffee, Back of the Swing coffee, fruit-infused water, and roasted garbanzo beans. Don't laugh if you've never had them. They're really tasty and crunchy. I like them very much. And we'll get back here, if you don't mind, in, say, 15 minutes. We'll play some music so you'll know when it's time. Thank you. Okay, did anybody want to give an opinion of the roasted garbanzo beans?
Like the screen, just hit that again, it'll come right back. Sometimes people
Accidentally hit that.
She's the plant in the audience says they're delicious.
Be good.
Okay, we have some great presentations following that break, and then I hope you'll still have an appetite because we're going to, after all these steps that you've been taking this morning, we're going to have an energy-balanced lunch. So, and I want to say what a gorgeous day it is. And when we eat sample this food out of the cookbook after this is all over, feel free to go outside. They've got this gorgeous area out here, outdoor seating, and feel free to take advantage of that. Okay, someone told me I'd get you back in here if I start talking about food here, so it worked. Okay, let's meet Dr. Jane Murray. If you don't know her, Dr. Murray has been involved in teaching and practicing medicine for over 30 years, as well as providing medical leadership as Director of Education for the American Academy of Family Physicians from 1986 to 91, and as Chair of the Department of Family Medicine at the University of Kansas Medical Center from 1991 to 98. In 1998, she founded the Sastoon Center of Integrative Healthcare in Overland Park, Kansas, where she works with colleagues from a variety of healing arts and uses natural therapies whenever possible. Her book, Be the Change, Transforming Healthcare from the Inside Out, is now available where books are sold. Now, Dr. Murray is going to give us the perspective we haven't heard yet this morning, and that is from the primary care physician. So, Dr. Murray?
Thank you. Although I have to say, as you heard from my introduction, I'm a little bit weird anyway, so this will be a little bit of a weird primary care perspective, because I do appreciate what was said earlier about when you're going through a cancer treatment, your cancer team knows everything about you. They've gotten to know you really well. They see you frequently. Sometimes you don't see your primary care physician all that much, and they may or may not be overly busy and have appointments that are awfully short and seem to be a little bit on the rushed side and not always sort of comprehensive. Now, one of my goals in healthcare is to change that, because I think we've got things set up completely wrong. And that's why I wrote a book about healthcare reform, but from a different perspective. And it's not a wild bestseller, so I took my husband's advice and kept my day job. But it was something I had to get off my chest, because I think we're doing healthcare completely wrong. And it isn't just about a primary care medical home and same-day appointments and group visits and some of the what I call kind of rearranging the deck chairs on the Titanic, because healthcare is really the Titanic and it's just not working for anyone too much, except most people like the individual providers that are taking care of them when they're sick. How many of you work in an outpatient setting? So the other's hospital setting? Okay, how many are nurses? Any OT, PT, respiratory, pharmacy, agency directors, social workers, psychologists, what am I meant? Doctors. Any doctors show up? Not usually. Okay. Bob, raised his hand. Doctor, yes. Okay, so I do think we need to redefine the role of primary care for everything, but for this discussion, for cancer survivors and specifically breast cancer survivors, because that's what we're talking about today. So I told Bob I'm going to kind of stretch your minds a little bit, because I'm going to talk about an approach to healthcare that personally I believe every primary care provider should be practicing, and I think in some time in the future they will be, but we're not quite there yet. Has anyone heard of functional medicine? Okay, good, because that's what I'm going to talk about. What about integrative medicine? Okay, that's hopefully what I try to practice, and I think really good primary care providers are trying to do integrative medicine, where they bring in the best of everything they can get their hands on, whether it's a specialist in medicine or a psychotherapist or a nutritionist or an exercise person or a community agency that can help a patient. That's what we should be doing, and that's why I went into family medicine in the first place many eons ago. So in general, the roles of the primary care physician, and I've got Lori's problem too if I can't really read these, but hopefully we're partnering with patients for lifelong health. optimization. Now, sometimes the payer system gets in our way and people's insurance changes and they have to change providers and they never have a primary care physician for very long, so that's a problem. But in the situations where we can, we certainly want to be partners with the patient. And that means wherever they go, an oncology team or surgical team or whatever, we get all those reports, we get all those records, and then we work with the patient to look at what maybe the long-term implications would be. I think it's important for us as primary care doctors and providers, nurse practitioners, PAs, et cetera, to really know what the resources are, because as you've heard, everything is a team effort. And if we didn't have Cancer Action and Back in the Swing and Gilda's Club and Turning Point and all of these agencies that are there to help people, there's no way I, as one physician, or me in my one practice, can have all of these wealth of resources for people that can benefit them. And then I think if there are things that we could be doing for them while they're going through treatment, the typical situation, honestly, is person gets diagnosed with breast cancer, they go to the cancer center, they get their treatment, I get reports. Once in a while I might get a call from somebody saying, I just have this question, what do you think about XYZ? But honestly, I often don't see them again until they're completely done. And that could be a year or more. And so I think we have some work to do in that regard. This whole idea of looking at people as individuals and providing personalized medicine that is really oriented around their lifestyle, I think is what's coming. I think we're going to realize now with genomics, and we've got pharmacogenomics where we realize some people shouldn't take a certain medicine because they're not going to metabolize it properly, or it's going to have a horrible side effect. There are certain drugs that the pharmaceutical industry insists the person have a genetic test, because if a person has the wrong gene, they could die from this drug, and no drug company wants to be responsible for that. So this whole pharmacogenomics, personal genomics, this is all starting to come to play, which will help us in the big picture in a lot of ways. Instead of saying, well, you've got hypertension, and here's the list of drugs I know how to use for hypertension, and the NCLB says use a diuretic first, you know, okay, well, what if I give you a diuretic and you have an allergic reaction to it? Even though the science told me that was the thing to do, in your individual system, it was totally the wrong thing to do. So as much as I believe in evidence-based medicine and we need to practice smart and scientifically, every time I give somebody a drug, it's an experiment. Totally. You all in healthcare, you know this. The public is sort of shocked when I say this to them. Oh my God, it's an experiment. So I'm an experiment. And as you're hearing, even about cancer, about recurrence and life after survivorship, during survivorship, the rest of your life, it's lifestyle. It's what you eat, it's what you think, it's how you move, it's how you relate in your community, it's everything. So this is where we're moving, I think, in medicine, is to personalized lifestyle medicine, which is sort of another name for functional medicine. And it requires that we understand an individual person's lifestyle practices and the environment in which they exist, physical, social, emotional, spiritual, relational. That to me, that when I was a medical student, that's why I wanted to do family practice, because it was supposed to take this whole social environment into account as you're taking care of patients. And then we should use food and medications and maybe sometimes supplements as indicated to help meet the patient's goals and their individual situation. And I think we're supposed to take a holistic perspective, and that's not a woo-woo word. Holistic just means you kind of look at the whole picture, which is what we should have been doing and should be doing all along. So I think the medicine of the future, which is sort of how I like to think of this functional medicine idea, is it's not, you get the diagnosis. This is what we're so good at in Western medicine. Oh, you have migraines. I have this box of drugs for migraines. If I know your diagnosis, then I know what drugs to give you. And this one drug for one disease, usually it's more than one drug. And then you've got side effects of the drug, and then you give another drug for the side. Oh, you can't sleep with this medicine, so let's give you something to help you sleep. Oh, and by the way, you've got 4 different conditions, and so now you have 4 different specialists, your dermatologist for your psoriasis, your neurologist for your migraine, your rheumatologist for your arthritis, and they've each got their boxes of stuff, and they're not particularly that interested or knowledgeable about what's going on in your other ologists' minds, right? So I get patients coming into me going, I just want a doctor. Could somebody look at the whole picture? And that's what I think all of us want, really. I think we need to look at the underlying reasons, and I'm going to go into some detail on this in a minute. What's causing the manifestation of what we call an illness? We're so good. We want to label. Name and blame is one way to think about it. Okay, I know your label. Now I know what to do. End of story. Well, why do you have that label? Why do you have migraines? Why do you have psoriasis? Why do you have arthritis? Is there something underlying that if we got to the root of that and we could get it fixed, then you wouldn't need the ologists. You'd be able to just live. I believe personally that if we would incorporate complementary therapies, things I did not learn in medical school, acupuncture, massage, mind-body practices, energy healing, you name it, even nutrition, because we don't learn that in medical school very well. If we would use those things at the right time in the right place for the right patient, we could have way better outcomes and probably at a much lower cost. I think also we have to work with patients to really emphasize that they're really responsible. And all this talk that we hear and we say about exercise and eating, and the only person who can do that is the patient. It's us, ourselves. I said last time, that's why I wear a big sweater. So it doesn't look so evident that I need to work on it myself. And then end-of-life care, although we're not really talking about that today, but we haven't faced that very well in American medicine. We don't like to talk about it. Doctors don't like to deal with it. Oncologists, for the most part, maybe until recently, have been notorious for never wanting to think about the end. No, we're going to fight this. We're going to fight it. And that's great up to a point, and at some point, we all have to admit there's an end. And how can we have that be dignified and peaceful and a healing end? But that's a different day. So this horizon, this new horizon for the future of healthcare is something that sometimes is called functional medicine. There's a whole entity, large group of people around the world now studying functional medicine. There's an Institute for Functional Medicine in Gig Harbor, Washington. They put on conferences that when I used to go to them, they'd have 200 people. Now they're completely packed at 1,500. They do courses all over the world. At these meetings, there are people from 100 different countries. I mean, this is really gaining traction, and I think you're going to hear more and more about it. I wish it was called something else, because functional medicine doesn't kind of mean a whole lot to most people. Unless you're in geriatrics, right? Functional ADLs. Or you're in psychiatry. This is a functional illness, not an organic illness, right? So I don't think they picked the right word. But anyway, it looks at the sources of why somebody has signs and symptoms that we call disease, and recognizing the uniqueness of each individual, so that personalized medicine, and then taking into account what's back here, not what they're presenting with joint inflammation or skin conditions or crying because they're depressed, but what's the antecedents, the triggers, and the mediators. So what are the things in the background of genetics and family history, early life experiences that could have set the stage for something under the right conditions to take on? So sort of the bottom layer of potential flammable material, okay? Then there can be triggers like an infection or an accident, an injury, a surgery, an emotional blow, a toxic exposure, that now that's the match that lights the flammable material, that if there wasn't a match, that stuff would have just laid there for even longer. And then what is keeping the flame going? What's the fuel that's keeping this flame going, the mediators? What's happening in the person's diet that's continuing to create inflammation? Their exercise, their lack of sleep, their interpersonal relationships, their level of stress, their beliefs. You know, people who have decided they're just a patient. I'm a breast cancer patient. And even after they're cured, their entire life is, I'm a breast cancer patient. You know, that mindset sets their cells up for certain responses potentially. So when we have these antecedents, triggers, and mediators that create disease, they can create these imbalances. And I'm going to talk about 7 major imbalances in the body, which helps me look at a person not with a label. Like I had somebody come in and said, I have eosinophilic myositis, and I want you to help me with that. What do I know from eosinophilic myositis? That sounds like some super specialty disease. They should be at Mayo Clinic for that. But I know what eosinophils are. I know what itis means. I know what myo means. So they got inflammation in their muscles, right? That's probably kind of allergic because it's eosinophilic. So I don't really have to care about the label. Like, okay, my curiosity is what's the process? Why are they having inflammation that's manifesting as muscle pain and a weird biopsy? So it helps me not get overwhelmed, because I do get a lot of patients coming to my practice because of what we do with very severe and long-term chronic disease, and usually multiple chronic diseases for which they are just tired of getting one more pill. They just like to feel better. So, or they've read about or thought about, maybe there's something underneath all this that somebody could figure out, and then I could get better. So these fundamental imbalances become defense and repair, so inflammation and immune function, communication, neurotransmitters, etc., hormones, all the communication molecules, assimilation, so how are you digesting and absorbing nutrients? And the GI tract, as we know, is like so pivotal in all the rest of our health condition. It's the outside world inside us, right? And do we have a good barrier? Do we have a good absorptive membrane, etc.? Structural integrity. Have we got spinal issues? Have we got absent, organs? Do we have, at the cellular level, membrane structure issues, which can be important? What about energy production? Oxidative stress. You hear about needing antioxidants because we're exposed to oxidation at all times. So the little mitochondria in our cells are the ones that take in nutrients and make energy. And those mitochondria get toxified and distressed and bothered by all kinds of things, and then we get fatigue and pain. And those are about, to me, the most common things people come in with. I'm tired and I hurt. Detoxification, biotransformation, that's kind of what the liver does. That's its job. It's there to do that. Do we overtax it with our environment, with all the stuff we take, the multiple drugs from the multiple ologists, and supplements? I have people come in with a suitcase of over-the-counter stuff they're taking. At some point, that's not always that healthy. And then transportation, all the circulation of the blood and the lymph and air and water and so forth. So if there are imbalances in these areas, you can see how you'd get diseases in there. So this is very busy, and in your book it's way too small, but the concept is this. Here's a tree. Each of us has a tree. We have these leaves up here. We have branches and a trunk. Roots, we're in the earth. We're exposed to air, water, hopefully nutrients in the ground, fertilizer, whatever. We spend our life in medicine right now up here. Is it working? Okay, it's not working. In the leaves, okay? And so what's written up here is all the different ologists, so neurology, hematology, oncology, rheumatology, neurology, all the ologies. We're up here in the leaves looking at brown sections. You got brown leaves in your rheumatology section. You got brown leaves in your dermatology section. Let's do some things to get those leaves green. We'll paint them green. Right? Now everyone's happy. You got green leaves. You got rheumatoid arthritis. Who cares that you're on Enbrel that's going to give you lymphoma in 10 years? Your joints feel good now, right? I'm serious. You are too. We got to look at what's in the, there it is. Yeah, it's not working. You got to look at what's going on in the substructure, the branches, the trunk, the roots. If the earth is bad, it's not getting good nutrition, the water's toxic, all of these leaves are going to go brown, and painting them green does no good. You got to get to the earth, the substance, the substrate. So that's really the point of this whole slide, and it gives us a way. Now this is going to look a little complicated. It's just a new way to think. And this is what we try to do when we're doing functional medicine assessments with people, is looking at these antecedents, mediators, or triggers and mediators over on the left, and then the various imbalances around that circle. And they're in a circle because they all interconnect. Think of that really as a web. So if you've got gut issues where assimilation is off, you may be having some leakage of antigens in there and your immune system reacts to them, and now you got an immune response over up in the defense and repair corner because your gut's out of whack. You've got spiritual disequilibrium from too much stress in your life, or divorce or deaths, that changes your neurotransmitters, which are communicators, which then changes how all the cells understand messages from each other. So everything is connected to everything. Oh, really? We aren't just these separate specialty organ systems. It does all communicate and work together. And then we can look at a person's lifestyle and help them find ways that could help themselves as well. So the antecedents are up here. The triggering events we can put on a timeline and even go from preconception, in utero, and then through life. And there's a lot of things we're finding with epigenetics. You guys have all heard of this now, right? How environment, nutrients, emotions, etc., can change the expression of genes. Okay, it doesn't change your genes. You've got your genes. But some of them are expressed and some of them not, depending on the environment they live in. And so they've done some experiments with humans that mothers who are depressed during pregnancy turn on some genes that create the initiation of more process of depression in their children. Rats that are obese, that eat an obesogenic diet, turn on genes in their fetuses that will create obesity in those babies. So, not to say any of us mothers should feel terribly guilty that we're completely at fault for our children's stuff, but things happen even that early on. So the antecedent, we said, family history, so genetic predispositions, trauma, toxicity, intrauterine history, like I said, sexual abuse, one of the worst things to happen to a young person for the whole rest of their life, emotional and physical development, many more chronic health problems in people with sexual abuse, tons more obesity, tons more dysfunctional relationships. I mean, that is to me like almost the worst thing that can happen to a child. All of these other things, intestinal permeability and so forth. So triggers. These can be physical or psychological issues, traumas, infections, toxicity. Memories could be a trigger. PTSD, we know, has a lot of power over how our system works. Surgery, big surgery, multiple infections, and so forth. So antecedents, triggers, and mediators, looking at a timeline. And very often if I sit down with somebody, and I don't do this with every patient, but those with chronic issues who have a lot going on, this can be really helpful. And you go through a timeline and figure out they had ear infection, so antibiotic, for 10 years, every 3 months. Their poor gut is completely out of control. They have no good bacteria in there. Now they've got all these autoimmune responses to things that if we can get their gut fixed, that can help. So the 3 legs of the stool are to look at personalizing these lifestyle factors. So down here we look at sleep and relaxation. So how is this person sleeping? Because I don't know, maybe I just get a skewed view, but if I have somebody in my practice who as we're talking tells me they get great sleep and they wake up rested, I'm like, my jaw's on the floor. I mean, most of us have trouble, I think, in this world with sleep and with relaxation. We don't know how to do that. 24/7 world, all the stores are open, all the ATMs are open, all of our computers are available, everything's 24/7. It's really easy to, I wonder what blah, blah, blah. Okay, I'll get up and look on Google. 3 a.m. Have you ever done that? Exercise and movement. You've been hearing a lot about that. That's crucial for how our body works. Nutrition and hydration. So, the colorful diet. And I always say this, is Jennifer here somewhere? About energy balance. Energy balance is important, but as she said, energy in, energy out isn't always the same. And the nutrients from what you eat is not just the calories. So that, 100 calories of sugar is not the same nutritional value as 100 calories of broccoli. And I think Danielle's going to talk about that too. That, it's the content of your diet, not just the caloric content. But what are the antioxidants? What are the phytonutrients? And we're going to hear more about that later. So there's something called functional nutrition, which really looks at personalized nutrition assessment, diagnosis, intervention, and then promoting optimal health through food, which is, let thy food be thy medicine, Hippocrates thing. And you can see how this is really nutritional input is critical to every single one of those 7 dysfunctions. So your assimilation of nutrients, your vitamin deficiencies, your enzymes, your fiber, I mean, all that stuff makes a big difference in assimilation. An anti-inflammatory diet or increased saturated fat as a negative, excess animal products, etc., impairs your immune system. So vitamin D intake, which doesn't really come from food, is incredibly important for your immune function, and so forth. And this should be in your handout. So you can see how every one of the functional aspects of the system really relates right back to nutritional issues. Water. Almost none of us get enough water. Every single cell reaction in your body, if you go back to biochemistry, requires a water molecule, right? So you got to have a lot of them for that to all work right. Stress and resilience, and there's so much being learned now about this, and we're going to hear a little bit later about some stress things, but stress is inevitable. We all have it. We're going to have it. We have to have it. We can't live and grow without stress, okay? Got to have it. It's when it becomes distress that it's dysfunctional and then harmful to the physical system. And how resilient is a person? What is their ability to bounce back from stress? And then relationships and networks, really important. And we know from really old research about breast cancer survivors that networks and support groups make a huge difference. Going through this alone doesn't work as well as having support. And that's why there's tons of support groups and all kinds of, now we know, things to help. So these 7 clinical imbalances are this assimilation, so digestion, absorption, and then what's the microbiota in your gut. We're hearing a lot more about the microbiome, right? This is it's a whole new organ system. It's a whole new universe of what's going on in there. And it includes breathing. Assimilation includes breath, so assimilating air, oxygen, and so forth. Defense and repair is the immune and inflammatory part of the body, infection, and so forth. So here's our spleen cells and our gut cells and our immune system making antibodies. The energy system, there's the mitochondria. Remember the Krebs cycle? The bane of everyone's existence, but it's absolutely crucial. It's so crucial. And, biochemistry got really given short shrift in medical school when I went. I think it still does. And because they don't teach it as human nutrition. They teach it as weird diseases that you'll never hear about. But it's primarily the mitochondria. Biotransformation and elimination. So this is the toxicity, the way our body naturally has processes to deal with toxins, heavy metals, pesticides, plastics, but we kind of overwhelm it sometimes, and then we can't deal with it. So here's all the toxic load we can get exposed to with things in our kitchen and our dental amalgams and work-related toxins, and there's our poor liver trying to do it all. But the skin is part of the detoxification system too, through sweat, lungs. We get rid of toxins through our lungs, through our gut, of course. We want to have good elimination to get all that stuff out. And then the lymphatic system is the little yellow guys. Transport, that's circulation, lymphatic, and so forth. And then the communication, which is all the hormones, which, every organ in the system deals with hormones, and neurotransmitters are incredibly important. Then the structural integrity, both the physical, body structure, and we know we can get people to feel a lot better if their posture's good, if they're stretching properly. We got people who are experts in this in the room. Helps everything, helps circulation, helps respiration, helps pain. And then what's happening at the cell membrane level? There can be structural abnormalities at that level as well to think about. So I think all of this thought, this whole new way of thinking about how the body works and how the systems work together and how everybody's one unified whole in which everything's communicating and working together kind of creates the opportunity for us to really offer this personalized health care. We look at then lifestyle, what the person's doing for themselves, maybe some supplements in certain cases, and certainly nutritional recommendations, drugs as needed, and then complementary therapies incorporated as part of the therapeutic process. So some people ask me, well, what's the difference between functional medicine and integrative medicine? And my thinking about it is functional medicine is a way for me to think about how things are going and what's maybe going wrong, and then we come up with some plans of how to investigate it and help it get better. And some of the things that can help it get better would be complementary therapies. So there's sort of more tools in the toolbox than just, oh, drugs for migraine. Now, you already heard this a little bit, so I'll breeze through it, but the influence of obesity on breast cancer risk is huge. So in the premenopausal woman, it's mainly due to generalized obesity, whereas localized fat distribution, that central obesity, the apple-shaped person, is specifically increases the risk in postmenopausal women. I'm sorry, premenopausal. I did that backwards, didn't I? Premenopausal women. Now, here's something I hear from patients all the time. I don't know if I should take estrogen because, boy, there's this really big risk of breast cancer. Being obese is 8 times more dangerous in terms of breast cancer risk than taking estrogen. And we don't ever talk to patients about that. You know, well, your BMI is 35. You should not take estrogen probably, and you really need to lose a lot of weight because that's where your breast cancer risk is coming. Blood sugar control, being obese increases the chances, and you saw that J curve she showed where the death rate is much higher in women with breast cancer who are obese. So that's not a good thing. And in premenopausal women who have breast cancer, the highest quartile of BMI has 2.5 times the risk. You saw that. Oh, here's the one about blood sugar. So again, much higher risk of developing breast cancer if you have diabetes and high blood sugar than otherwise. So here's another schematic. So at risk tissue would be the breast, the garden. You're the gardener, or the patient's the gardener. And some of the risks are no pregnancies, late age of pregnancies or fewer pregnancies. Those are risks for breast cancer. All the oxidative stresses of things that could create weeds in the garden. Oxidative stress, radiation, getting older. Then estrogens could be considered in many cases, not all, but many cases as the fertilizer. And so there's all these things that can increase estrogen in the system. You don't have the enzymes that convert it to more benign types of metabolites. You have more inflammation, you drink more alcohol. All of those things are create more estrogen, and then that's the fertilizer. So when you get too many weeds in the garden, you could get breast cancer. So that's a way to think about it. So thinking about this personalized lifestyle factors in general for breast cancer survivors, you want to think about these 7 imbalances. You want to maximize circulation, which is that transport. What does that? What improves circulation? Movement, exercise, water. Singing, did you say? Cinnamon. Okay, so you improve transportation. Reduce inflammation. How do we do that? Through lifestyle. Diet. Yeah, cut the sugar, cut the alcohol, cut the red meat, cut the processed foods, anything with labels you have to read and you can't pronounce what it is. More inflammation, okay? What else about inflammation? Yes, because stress is an inflammatory marker or producer. Okay, improve biotransformation and detoxification. How do we detoxify? More water, so you get it out through your kidneys? Cleanses, or good fiber, getting your colon to be able to empty on a at least daily basis. Absolutely. Take in fewer toxins. Try to be careful. Certain things may be organic foods, not everything. Try not to eat out of plastics that you put in the microwave. You know, blah, blah, blah. BP. Are you talking about that? A little bit. BPA is in the lining of cans. You know, all the things we get exposed to that we know are bad for us, and particularly for breast cancer risk and xenoestrogens. Good. What else? I didn't hear. Exercise, yes. You sweat, and you get it out that way, and you breathe deeply. So meditative breathing, yoga breathing, all of those things are good detoxifiers. What else? Get rid of toxic people. It's probably one of the more important ones. Seriously. Yeah, you got to do that once in a while. Just say no. Well, like I'm in a group of women health professionals, and it's a nice group, except this one person is really obnoxious. Really obnoxious. And it's all about her. And every time we meet for dinner, it's all about her. And, you know, so now the rest of us are like, I can't make that day. No, I can't make it for the next, 5 years. I finally sent an email yesterday to everybody and said, you know, my life has gotten overly busy, and I just don't think I'm going to be able to participate in this group. I wish you all the best. I didn't have to hurt anybody's feelings. I just said what I needed. And I feel so good. Exactly, and so the other 4 people, I'll go out to dinner with them, and we'll start a new group. Actually, that happened to me once in elementary school. I started a club. I forget, it had a cool little name, and I had all these girls in my club, and we had dues, and we put them in a little tiny, well, I'm old enough that we had, it was a little thermos for a doll. And it was a little metal thermos with the top, and we put our little quarters in there, or pennies, or whatever it was, and buried it in the schoolyard in a faraway corner, and that was our dues for our little club. And then one day I came, and they go, we decided we're not in the club anymore. And we started a new club, and you're not in it. And they took the money. So that was a lesson. All right, so then balancing neurotransmitters and hormones, and that's tricky in people that are on hormone blockers and have hormonal symptoms and can't take hormones. But there are a lot of things that can be done through nutritional support and sometimes supplements that are safe and so forth. Optimizing structural integrity, how can we do that? Core exercise, absolutely. Strong core, Pilates, balance things. Posture, absolutely. Good. Maximize energy. Everyone's goal. Exercise, good sleep, healthy food, enough water for all those little mitochondrial activities to do. Keep the inflammation out. When I tell patients about the mitochondria, I go, look, that's like a little machine, I promise, 30 more seconds. It's like a little machine with cogs, takes in nutrients, pumps out ATP, little energy packets, right? Goes around one cycle. Now the electrons are oxidized. That's why we talk about antioxidants. So we get the electron transport chain reoxidized, and then it can go around again. So you eat blueberries or tomatoes or spinach, things with high nutrient content. It just spins. You drink a Coke, you just poured glue into that machine. And they're like, really? So yeah, keep it spinning. I told my brother this story. I learned this at a meeting, at one of my early functional meetings about blueberries. Oh God, look, we can eat blueberries and our mitochondria are just spinning. And he goes, doesn't that make you want to hate to eat? I'm like, no. Okay, optimize assimilation of healthy food, air, water, and thoughts. I think that's something we don't always put in the formula. So how do we do this? Personalized nutrition plan, we're going to hear more about that. Personalized exercise movement plan, stress management, mind-body plan, test for and reduce toxins. There's ways we can do that. Evaluate gut function and repair the gut as able. Optimize sleep, rest, and relaxation. Care for personal relationships, including yourself. Because it is very easy to give, and then, oops, those oxygen masks came down and you didn't put yours on, and you're trying to help everybody, but oops, you're dead. So it's not selfish to have your mask on first. Care for personal relationships, including yourself. And then find spiritual peace. And I think a lot of times when people get a cancer diagnosis, it's shocking, it's horrible, it's hard, it's difficult. But after they're through it a little ways, how many of them say, I've learned a lot in this process. It's brought me to a new place in my life. As weird as it seems, I'm kind of glad I got cancer because I'm reassessing my priorities. I'm realizing what's important. I realize who I should say no to and who I need to say yes to more. And often service is something that helps people when they're feeling kind of down and bad about their own situation. To do something that helps others is kind of uplifting. So we start where we are. You're going to hear more about the Back in the Swing cookbook. It's an awesome resource for everyone. I've never had breast cancer, but I love that book, and every single recipe I've ever made is fantastic. So thank you very much.
I'm going to ask Dr. Murray to please stay up here. We're going to have a little, by the way, I was wondering why I never got invited back to that group. And it's nice to have that answered today. Anyway, if some of our panelists would make their way down here, we're going to ask Dr. Klemp. We're going to have a moderator, and we have a surprise guest that I want to introduce, someone who is going to share the survivor perspective. They actually couldn't make it, so they sent us a little video, and why don't we go ahead and show that.
When I was diagnosed, one of the doctors that became so important to me ultimately said to me, try to do all the things that are normal to your life so that your life maintains some sort of support. It feels like your life, like you're not all of a sudden stepping out of your life. I put cancer survivor as one of the things that I am. But what I really am is a mom. I'm a musician, I'm an artist, I'm a hard worker, I'm a family member, I'm a volunteer. There are all these things that are who I've always been. And now I'm a cancer survivor. My life really was from that point forward about listening to what I needed, my body needed. It was about not defining my life by cancer, but refining my life. I got to sort of start over and write my own forward to my life. I incorporate what I know is great for me and my loved ones, which is eating great. And I gird myself with information and with serenity, with just healthy living, healthy outlook. Hi, I'm Cheryl Crow, and I'm proud to support Back in the Swing.
I'm Cheryl Crow, and tonight I'm going to be raising my voice to help cancer survivors get back in the swing.
Your life doesn't stop at cancer. It doesn't begin at cancer. It is a moment in your life that is a part of your experience. It's what you do with it afterwards that really ultimately winds up mattering. Always back in the swing, yes.
Okay, if Dr. Klemp and Dr. Murray come on up, and I'm going to introduce our moderator, a woman I know very well. Over the past 30 years, Barbara Unell has authored 15 books on family education and health. To fill the void in personalized, multidisciplinary breast cancer survivorship clinical health care, Barbara founded Back in the Swing USA. Today, this national nonprofit is the first and only grassroots organization exclusively dedicated to providing education and awareness for cancer survivors and providers in multidisciplinary personalized clinical health care and academic medical research in the growing field of breast cancer survivorship. Andrews and McNeil published the book she co-authored with Judith Fertig, the Back in the Swing Cookbook, recipes for eating and living well every day after breast cancer. So I introduce to you Barbara Unell.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you so much for being here. It's really a dream come true to see all of you here learning and soaking up. But I think there's one thing missing, and I think we just need to stand up for a minute. Just stand up and take a deep breath. We've been talking about moving. We've been talking about standing. We've been talking about just stretching and making sure that we all keep all those different words that Jane Murray talked about moving. And so just breathe in, breathe out for a moment, and just kind of rehydrate ourselves with good air, all right? Because you've heard a lot of information today. And as Sheryl Crow said in that wonderful quote that I really love about it's what you do afterwards that matters. The message from today is actually after that diagnosis, as we talked about and as Dr. Klemp talked about when she began. And indeed, that was and is the ultimate purpose of Back in the Swing. It's our name is our mission, as we say. And so for 15 years, we've been funding and fundraising and creating these various services and studies and protocols that have been at your access. They're for you. And as I say, various talks I give, you have the people. Go take this to the people because you have access to just the 100 people in this room or 75 people totally maybe in this room that we've been gracious enough to have serve. You see another 1,000 people, let's say, in the next year, another 100 people. Just think about the multiplication of this data. And that is why Judith and I are so proud also to have written the Back in the Swing Cookbook. We love that book. We love being authors. But most of all, that book is for you to take and spread that information. We were talking about it just a few minutes ago. To take the data that is in that book that you may not have time to talk to your patients about. So that book is there for them, for the 364 other days that they can't be in your office getting that data and that small amount of time that the practitioners have to spend. How are they going to have, without the notes that they take, all those research studies that we talked about, that Dr. Klemp talked about, Dr. Murray and others, and I'll call her Dr. Cristofano, she's not quite doctor yet, but she's about getting her PhD, is going to be talking about, it's in, as we say, the book. And in fact, I'll call you Dr. Dr. LaRue, I'm sorry, who's going to be talking, and Dr. Klemp and Jane Murray. They are in the book as well. They were chosen for this day because they do great Vanna White, but also because they are practitioners who understand this transition that people make. That moving forward is what we're all about. And so to that end, I am thrilled beyond words to introduce these two people in a complementary setting. In other words, usually there's a silo situation, right? The primary care provider and the oncologist office, whoever that is in the oncology office. But today, I feel like Las Vegas, for the first time on the same stage, here they are. And so I am here to take your questions about that transition. As Sheryl Crow said, it's what you do afterwards that matters. And so something maybe you've been wanting to ask, again, on the same stage at the same time about that transition, because that's ultimately the goal.
I know one of their first questions.
What?
Can I sit down?
Yeah, sit down. But I'm glad you were standing because as Dr. Cristofano will tell you, standing is also important. So it's okay, sit down. Thank you. But really and truly, our whole goal is to get people moving, as Dr. Klemp and I have talked so many times before, out of the cancer center setting and into a regular ongoing wellness setting where they would see Dr. Murray or other practitioners when they have inflammation, as it were. So, questions? They're here to answer. Yes?
I'm sorry. I'm trying to get it all on video.
I have a question about the shingles vaccination. Do you recommend that for your for all your survivors? And how do you feel about anybody who's 55 and on?
Yeah, it's officially, the shingles vaccine, Zostavax, is officially approved for people over 62. It can be given to anyone that the doctor, says. I think it's a good thing to get. I was waiting for a few years after it first came out to be sure it wasn't one of those, oops, it's got these side effects we didn't realize until we put it on 1 million people. It seems to be extremely safe. You know, it's pretty painful. I don't know if you've had one, but okay, so I had mine last year, and it hurt for a long time. But that being said, the only downside to it is 2 things to think about. One is it is not 100% protective. People can still get shingles after the vaccine, and I've had a couple patients who, you know, a year after their vaccine got some shingles. And one was a pretty bad case, so it isn't like, oh yeah, but it'll be a lot milder. And I don't know, maybe it would have been even worse if she hadn't had that shot. You have to be sure you've had chickenpox, absolutely sure you've had chickenpox, because it's a live vaccine. So if you aren't sure, then you should get a test that looks for varicella antibodies to be sure that you have the antibody, then you can get the shot. The other thing is, if you're going to get the shot, you shouldn't, because it's a live vaccine, you don't want to be around somebody who is immunosuppressed, and certainly you don't want to be still in any kind of scenario where you're immunosuppressed.
And there's also, if you look at the NCCN guidelines on survivorship, there is the immunizations sort of recommendations, and I find that most of us don't practice that. So if you look at that too, that could be put into your note for your patients too. Yep.
Right there, pink sweater.
With healthcare the way it is and them trying to push volume instead of value for patient visits, how do you address that when you go to your primary care and they only have 15 minutes to get all of this stuff in?
Well, if you come prepared with a list of the things that are really important, or the patient comes with things that are most important to her or him, if you have a survivorship plan, which is going to be more and more common coming up every year now, to go over that, particularly the issues that the patient feels is really the most important to them, I think could facilitate that. Because you're right, in the real world, those visits are short, and there's not always enough time.
And I think it's also interesting, I was telling Dr. Murray, I had a meeting out at AAFP last week on Tuesday, and one of the questions that we were talking about was, you know, how do we get some of this education to the family practice physicians? And the gentleman I was talking to, who's one of their medical directors, said, you don't understand, everyone that comes and talks to us has something that is the priority for, you know, our education and our patients.
Yeah.
So I think that one of the things that we've tried to do in our notes, which is to say, okay, who does what? And if you read any literature about patient-centered medical homes or oncology patient-centered medical homes, I feel like that's what we take on in survivorship a little bit. It's not a formal, you know, we haven't taken on that designation, but you end up delineating who does what. And by doing that, then Dr. Murray gets her specific, okay, I know I need to do these things in addition to the other stuff for that visit. So I think it can really target that more. So I feel like that we in oncology, as we get the patient sort of moving out of that acute setting, have to be more of the quarterback, and that means we have to tell everybody what the plays are. And so I think if you frame it like that, then our primary care partners can be more efficient with what they're doing. And then also, I did coerce this gentleman from AFP to at least think about, you know, how we're going to get this out, and they are supportive of that. So I think we need to get that out into the tools to the hands of the folks on the field.
But I'll tell you what, I mean, the role of the patient is not insignificant at all. Look at all the big changes in healthcare that have happened. Like, my favorite one is birthing centers. You know, some really big-minded obstetrician did not say, hey, I got this idea, let's have a birthing room, and it'll be completely different from the labor and delivery things that we've all been used to, and we won't shave the women and give them IVs and make them take an enema. How many of you remember those days of birthing? We'll let them labor in a room that looks like a bedroom, and if they want to walk around, they can walk around, and their family can be there, and they can play music, and they can have a doula. No, that only happened because patients demanded it. They said, we don't want this to be an illness thing. This is a natural activity of centuries, eons of women's lives, and it's a natural process, and we should not make it a disease. And the doctors were kicking and screaming for years, for decades. And the doctors that sort of accepted that and said, yeah, you know what, that's a pretty good idea, they suddenly got all the OB patients. And the hospitals now vie for who's got the best birthing suites, you know. So the only thing that, honestly, that really changes healthcare, other than some dramatic, huge new finding like penicillin, you know, is the patient sort of saying, here's what I want, here's what I need, and patients coming in to a physician with a survivorship plan that they got from their oncologist. Maybe the doctor didn't even read the notes that came, that you guys are great about sending. I don't have an electronic record, so I get them faxed to me. Now, I will say they make my charts awfully thick, but that's okay. Then you're triggering the doctor. And I will tell you, my behavior has changed over the years because of a patient coming and saying, well, what about X? I'll go, gosh, I never thought about X. Maybe it's not that important. The next patient, what about X? Oh, you're the second person that's asked me about that. You know, the 50th patient, I better be ready for X because otherwise I look like an idiot. And I'm not doing the right thing. So you guys have power.
And I think the other piece of that is the patient obviously advocating for that, but also, I mean, I can particularly talk about Dr. Klemp standing right here. I've known her for a very long time, and in the beginning, she was really a champion at the University of Kansas Cancer Center, as was back in the swing, for this kind of survivorship clinic, all of that you've heard about today and that Back in the Swing is funded for all these years. It started really with an internal champion.
Right.
And Doctor, you can talk about that
does
across
make a
the country.
difference, right.
But you can be, and I'm looking around the room, I know who you are, and I know who's my next call. Could be that champion inside your healthcare centers, right. Your medical centers, because you know there is a sense of perseverance. That this is not, this is today. It's a long time coming. But we are not there, whereas this is just standard of care, as Dr. Murray was saying. Those birthing rooms are not everywhere yet. Same thing here. So I'm part of this is a call to action on your part to go back to your healthcare providers and take this information, but also take your passion for taking care of folks. And you can talk to that too.
Sure. I think the bigger thing is this is also a business, and you need to have your clinical hat on, but you always have to have your business hat on, because none of us will survive if we're not thinking that way. So the hardest part is being okay with that. And it doesn't mean you have to like it. You just have to be okay with it, acceptance. And then then I think the other piece is that there's a lot of things we're being mandated to do that have no evidence. So a care plan has no evidence. And trust me, that causes me a lot of pain, which is why we're trying so hard to work it into the workflow. I don't want to make our cancer care teams do more than they have to, so we have to build it into a workflow, and it becomes a natural part of the process. But behavior change is hard, and so I guess people think if they make it a mandate, then we have to do it. And even if you're not from an accredited organization, the people across the street are, so that makes us all benchmark against each other. So I think the bigger thing is it needs to be part of a clinical workflow. It needs to be part of how, when we start now, we've just been meeting with our nurse navigators, so they're actually going to help us start our care plan note. They document fertility, they document genetics. They also get a lot of history from the patient. So we're actually having them start that, and that's going to be part of our process. So instead of trying to do all this stuff at the end or wishing our electronic health record did things for us, we're going to start from the patients walking in, because frankly, I think it's a little easier that way. And it can start doing that change, and then each person knows their role. So it is a journey. There's no right way to do it, but we have to kind of figure out how to do it. And we bill for everything in the survivorship center except our navigator or our coordinator. So it is a billable service. From your hospital standpoint, it does make them money. So you just have to put the two pieces together.
And I think back to the coordination here, Dr. Murray, you want to mention a bit about how helpful that plan will be for you, because of the data that's going to be.
Oh, yeah. I mean, and Jennifer and I are actually talking about how we could come up with something maybe that could help the American Academy of Family Physicians get this out better, a simple summary of what's happened, what the person had, what treatments they had, what complications they had. Now, what's the really a checklist of things to follow and things to do? Like, not every person on the planet, for example, needs a colonoscopy. High-risk people do. Well, now someone who's had cancer is a high-risk person. So now I got to be sure that I'm tracking on that. I'm tracking on.
So we need a checklist for the primary care physician to know, okay, these are all general things you should be doing anyway, but because this patient had cancer, this is now how that needs to look for you. Because they don't have that instruction. There's nothing out there for them. So we need to give that to them.
And it's kind of overwhelming. And so if I don't have sort of a template, either from the patient or from the cancer center or whatever, my specialty society, but it has to be patient specific,
Right. Oh, yes.
Yeah.
Even the business end of it is all data driven.
Correct.
So I think it's important that we include them to figure out there are people that still have not gone to electronic
Yeah, yeah.
Well, and I think the other piece actually, we're sitting here talking about this, and I know there is a director of a supportive care agency in our midst here, and I just was thinking about how helpful it would be also for an organization like Cancer Action or Gilda's Club or Turning Point also to have this data from the medical data to drive to understand the antecedents back to Dr. Murray's comment for depression or for issues that present themselves to the social workers at those agencies. And hopefully we'll do this again, and I think it'd be helpful at this juncture in this discussion to include them in this conversation because
Yes.
again,
So
that's this
I think
multidisciplinary approach.
It's a very good point, and I know we've talked for years about how do we have some sort of communication, because if you're sending a patient to Cancer Action, they're going to be talking to a social worker, and you want to know that your patient's doing that referral. Because of those standards, distress screening, all that, if you assess for something, you better have a next step for the patient, and a lot of us don't internally have that right next step. We're lucky at KU, we have a psychologist, we have fellows, we have all kinds of people who we can use for that, but a lot of community practices have to use those community-based resources. So if we're going to check a box on a referral, because all those guidelines, you can check a box for referral. How many patients go to referrals, right? So for most things, it's 30 to 50% drop off, easy if you're referring them to something else. So how do we make sure there's a feedback loop? Luckily with Turning Point, we now have them actually documenting in the chart, so we know if they've gone. But we have to develop these feedback loops because they are providing health care for our patients, and unfortunately we don't always know that they are, and that's a good thing that they are, but we have to develop that feedback loop. So that's an ongoing challenge. And Carla, you can chime in.
Yeah, and I have actually been talking to some of our healthcare partners about how we can do that, particularly in that area of distress screening and identifying distress. The earlier we can, the better the intervention is, and so how we can partner together, not only in terms of identifying it and how we're going to treat it, but how are we going to measure the outcomes within our community and within our community resources that I think will be helpful back to our healthcare partners and be good collaboration in that way.
Yeah.
And so maybe we can actually do, just like we're doing with our nurse practitioners, one of the things we did with Turning Point, since they are part of the KU family, is we did put a quantitative measure in using the PROMISE tool. So if any of you know, you have to find some validated tool that works. So we implemented last year using their overall aggregate plus anxiety and depression. And so we measure people baseline 6 months, 12 months, and then if they participate kind of in a more targeted intervention. So we know from that data, and we have over 400 patients now that we've collected the data on, not only does depression and anxiety decrease, but their overall quality of life is increasing. So organizations such as Cancer Action or Turning Point, we are getting data to support that, and that's something you need to know too. So it's not just a feel good, we send them off to somebody and we can check our box. This is actually improving that quality and quantity of life for them. So those are things where we can chat offline, but if we're all using a similar measure, then that helps you as a provider know your patient's actually getting a benefit from that service.
And while I have just the ears of so many, I just want to let you know that, and I have 3 of my master social workers here today to hear this information, but when you send somebody to Cancer Action, they are meeting with healthcare professionals who have been trained in their field of study to be able to help be some of that psychosocial support.
Great.
Great. And any other questions? Yes.
Just talk loud.
She can hear.
She can, yeah.
We can hear.
All these different arms are fantastic. I'm just thinking, as the patient, how do you keep from overwhelming the patient? Because they already feel like they've been hit by a Mack truck with the original diagnosis, and they've got all the physical things that are going with it. And now you're saying, okay, and now I want you to change the way you eat. I want you to do more exercise. Well, I'm just.
Yeah. I so relate to your question, and I at the risk of sounding self-promoting, I want you to take a copy of the Back in the Swing a companion guide that's up there at the table, at the Back in the Swing table. We'll have some volunteers afterwards. The publisher did the companion guide to talk about the Back in the Swing lifestyle, which are the 5 elements that you've been getting information, very fantastic information, deep information today about. The 5, and it says it in the front of the little book. Those 5, in my opinion, are the blueprint for that patient to look at. That's exactly what we've been talking about today. One's nutrition, one's movement, one's survivorship-specific medical care, which is, of course, in the Survivorship Center that Dr. Klemp and Lori Renal have been talking about. Nutrition, you're going to hear about. Danielle Cristofano really is going to talk. Poor thing, she's just been so patiently waiting. She's going to be digging deep into that subject. There's also Carol LaRue, who's going to be talking about mindfulness and relaxation, which we've been hearing about today, and also the fifth one being in movement and then positive emotions. All that is, there's a science-based information in the book, the Back in the Swing Cookbook, for this very reason. When you drill it down to these 5 areas, whenever I talk to anyone, because I talk to a lot of folks who contact Back in the Swing, for this very point you're saying, I break it down into these 5 areas. They include the research-based, the oncology continuum there, the medical care, if you will, but also those other 4 areas that they have complete control over when they look at how they can access those positive steps. It helps them feel a sense of control again, but it also helps them have then the 288 pages when they get the book that then helps them understand a little how to put that into action. Because it's one thing saying, you know, it really is important. You look at this data on nutrition, it's so important. We have, and I say we, because we're going to talk a little bit more about that, we have the key foods in this book, in the 4 areas that have been proven to help reduce risk in terms of cancer and other diseases as well. They're in the book for a reason. They're in the book because it helps to simplify that for that patient. And we're very proud to know that Duke and Yale and Sloan Kettering and MD Anderson and now KU and folks in Idaho, across the country, cancer centers are using this book for that very reason, because there's no other resource like this, because people need in the comfort of their own home to start, what can I cook even? And that's where the recipes are. So I love your question, because I think it's, the bottom line is we're all here today, but then how do you help that person in your offices? And I'd be delighted to talk to each one of you how to make that happen, because that indeed is really a missing piece that we've been working so hard at trying to get out into the where you have access, as I said, to the people. Thank you.
Okay, thank you all very, very much. And Barbara, you stole my little presentation later because several people have been asking, and Penny Schaefer told me some people are asking, how do we get these cookbooks? And one of the things I'll just add to what Barbara said is our publisher, Andrews McMeel, they're a national publisher, so the book is being sold all over the country. And the point I want to make is that they have said to us that any healthcare providers who want this book can actually, so it's not our book. We didn't self-publish it. But they are making this book available at, I want to say, $12, a copy, which is what booksellers buy it for. So, and there could be some funding streams, too, to help you if you want to provide these to your patients. Okay, so let's introduce Danielle Cristofano. Danielle has an undergraduate degree in biomedical sciences from Marquette University and a master's degree in dietetics and nutrition from KU Medical Center, and is currently a doctoral candidate in the Medical Nutrition Sciences program at KU Med, and will be finishing her PhD in November, which focuses on alleviating insulin resistance and metabolic syndrome among breast cancer survivors. For the past 3 years, she has worked with Dr. Christy Beffert in the Department of Preventive Medicine on several studies focusing on weight management among breast cancer survivors. She is passionate about cancer survivorship and the key role nutrition and activity play in promoting wellness and longevity. So please say hello to a person with at least 10,000 steps already today, Danielle Cristofano.
You hear me? I feel like I'm a loud talker. So our research really focuses on how we can help breast cancer survivors. So our mission is to empower women who have survived breast cancer to reclaim their health and well-being through scientifically driven, expert-led, and peer supportive programs that promote healthy eating, physical activity, and long-term successful weight control. So that's a huge mouthful, but we try to do all of this all at the same time. So throughout our interventions that we use, there are three main components. And the first one is what I referred to earlier, and it's energy deficit. So I know not all calories are created equal, and Dr. Murray alluded to that earlier, but energy deficit really is important for weight loss. And in order to produce an energy deficit, we encourage 1,200 to 1,500 calories per day. And we do this through prepackaged foods. So I know a little bit of controversy there. If you can't read the label, you shouldn't eat it. But we have found that prepackaged foods like lean cuisines, healthy choice meals, even Progresso soups at the grocery store tend to be really helpful and effective in helping people to lose weight and learn portion control. We also recommend fruits and vegetables. As many fruits and vegetables as you can get, at least 5 1-cup servings per day, but again, as many as they can get. And then increased physical activity is something that we focus on a lot. That helps toward this goal of energy deficit. And then the next component is the cognitive behavioral modification component, which are a lot of words to say that we want them to change their behaviors. Obviously, we can say all of these things are good for them. We can say lose 10% of your weight, but what does that really mean? How do they actually change those behaviors? And we do this through self-monitoring, which I'll talk about later, goal setting, stimulus control, cognitive reframing, and problem solving. We focus a lot on problem solving during our interventions. And last but not least, we tie all of this into breast cancer survivorship support. So this isn't just about weight loss through diet and exercise. This is about how do those things relate back to breast cancer, and how do they relate back to your risk of recurrence. So to talk just briefly about the self-monitoring components that we use them because they are the strongest predictor of successful weight loss. And when I say self-monitoring, I'm talking about recording behaviors. So writing down what you eat, recording your diet, writing down how much you exercise, monitoring your steps with your pedometers. And this helps us achieve the following. So awareness, accountability, consistency, and knowledge. And more self-monitoring is better, but some is better than none. So some people are totally overwhelmed by this idea of monitoring everything that they eat. And so we say, hey, well, maybe just write down or look up the calories in those meals that you have at restaurants. Or are weekends problematic for you? Write down everything you have to eat on the weekend. So there are ways to kind of work into this gradually. It's easier, obviously, with practice and experience. So in some of our studies, we've been able to use some apps and fun activity trackers to help promote self-monitoring. So in my dissertation work, we used the Fitbit Zip. I don't know if anyone is familiar with Fitbit, but it's a really fun way to measure your steps and look at your activity. And like I said before, awareness is one of the very first steps in all of this. So learning how active you really are and then working with your baseline level to kind of make changes from there. We've also used the ARIA Smart Scale, which is also a Fitbit product, which as soon as you step on it, it goes through the wireless system and tells you your phone and tracks your trend throughout time as far as your weight is concerned. And then Lose It account. So this is a great way to track your daily caloric intake and what you're having on a daily basis. Does anyone have experience with apps like Lose It or MyFitnessPal?
That's one of my favorites too.
Lose It?
Yeah, because I like using scan labels.
Yeah. Yeah, so our participants find it extremely useful. There's also a new app called Health Watch 360, which I really like as well. So there are lots of options out there to help you record your daily intake. If you don't like technology, a lot of the women we work with a lot of them are in rural areas and maybe don't have a lot of access to broadband internet like we all do. And then a lot of them are maybe a little bit older and just have this aversion to technology. And so paper works just as well. writing down what you eat on a piece of paper works just as well as tracking it in an app. We use this Calorie King book for our participants that we work with in rural areas because it has a good comprehensive list of any food and the calorie amount, the fat grams that you can imagine. Goal setting is another key component that we talk about with our breast cancer survivors, and we use this acronym SMART. So it has to be specific, measurable, achievable, realistic, and timely. So not so smart goals would be things like stop eating out so much or lose 75 pounds in 3 months. Not realistic, not attainable, not time-bound. Exercise more is another one. I mean, we all say we want to exercise more, but what does that really mean? So we find that it's helpful, and we don't just find this, research finds this, that SMART goals are very effective in actually making behavior changes. So limit restaurant food to once per week for the next 6 months is an example of a SMART goal that we would use in one of our studies. We do all of our group sessions by conference call. So we find that this gives people the freedom to go about their busy lives and just call in once a week or once every other week and meet with other women who are kind of going through the same thing and have similar goals. So some of our results that we've seen thus far from the studies that we've done are significant. So we have found that by using the strategies I just shared with you, we can achieve clinically meaningful weight loss, which is where we see the most health benefits. And this isn't just weight loss, obviously. They achieve this weight loss through things like increasing their physical activity levels, so burning an extra 1,200 calories per week, decreasing their caloric intake by 350 calories per day, increasing their fruit and veggie servings, and decreasing their percent of calories from fat. This also produces significant quality of life changes. So when people eat better, when they lose weight, when they exercise more, they feel better. But we have this maintenance problem. So we lose the weight, and we do a great job. We know how to do that. We know how to do that really well. We know how to help people lose weight. It may be hard, but we know how to do it. But the problem is people tend to regain weight, especially over a 4-year period, with up to 50% of weight being regained after 1 year of that weight loss. So that's a problem, and that's something that we're really focusing on right now in research, is how do we address this maintenance problem? What we know so far is that these treatments have to be really long-term. So this isn't a sprint to lose weight. This is a marathon. This is a lifelong marathon. It has to be a lifelong behavior change, a lifelong lifestyle change. We use things like effective problem solving in the maintenance phase, continued self-monitoring, and extremely high levels of physical activity are required to maintain that weight loss. So over 225 minutes per week. So it's really hard to get people to work up to that amount of activity, and those are things that we're working on in research right now. How do we do that? One of the trials we have going on right now is 208 rural breast cancer survivors. So this is across areas of Kansas, Nebraska, Iowa, a few in Missouri. But it's a randomized controlled trial. So we have 2 groups. And one of the groups gets our, they both get our standard weight loss intervention. So they lose 10% of their baseline weight. And then they either are randomized to get a continued maintenance intervention over the phone, or they get newsletters on a bi-weekly basis. So we're kind of looking at the difference between what do the newsletters do compared to the continued phone treatment. And then we're following them up to 24 months. So it's a 2-year-long study for each person that's enrolled. So we're going to look at what happens long-term with these women. And a newer study that we just finished up last April, and this is a part of my dissertation work as well, is looking at how does sedentary behavior play a role in weight maintenance. So can we get people to lose weight, eat well, exercise more, and sit less? The answer, unfortunately, was it was a lot harder than it sounds. So it was really hard to get people to sit less, and that's something that we're continuing to work on in research. So now to switch gears a little bit, that was our research, what we've done. I'm going to talk now more about the nutrition side of things. So what are these simple tips that you can take home with you? And I thought we could start by doing this quiz. And this quiz is from the American Institute for Cancer Research. It's a patient quiz asking how healthy is your diet for cancer prevention, and I'm talking primary prevention and secondary prevention. So this is important for everyone, people who want to prevent cancer, and it's also important for cancer survivors. And the answers to these quiz questions are going to be obvious. You know, you're going to pick out what the healthy answer is, but I think this quiz is more about awareness, just being aware of where you can make changes. Before I get into the quiz, there are several patient-friendly tools that you can use with your patients, and one is the American Institute for Cancer Research website. They have a specific spot you can click for healthcare providers, and I have found this really useful in working with participants because they explain things in very plain language that participants can appreciate and then take home with them and make meaningful changes, and that's where this quiz comes from as well. But also the cookbook is a really important tool that you can take home and use with your patients, or ask your patients to go out and buy the cookbook, because a lot of what I'm going to be talking about next is in the cookbook. So especially the introduction of this cookbook, there are lots of really good, easy tips for breast cancer survivors to take into account. Okay, so with the quiz. Breakfast is usually, and you're going to write down 1, 2, or 3, egg white omelet and sausage, a muffin and orange juice, a bowl of oatmeal or cereal with fresh or dried fruit. So you're going to give yourself 1 point, 2 point, 3 point. You can do it if you want, or you can just follow along with me. I think it's fun to do it because you got to practice what you preach. So give yourself 1, 2, or 3 points. The next question, thinking about the amount of meat in your diet, do you always include a large portion of red or processed meat with your meals? Have a medium-sized portion of red or processed meat 5 or more times per week. 3, usually fill at least 2/3 or more of your plate with plant foods and 1/3 or less with lean meat. So again, give yourself a score of 1, 2, or 3 and add that to the previous answer. If you think about the meals and snacks you've eaten over the past week, your choices of plant foods have included 1, less than 10 different kinds, 2, 10 to 20 different kinds of plant foods, or 3, more than 20 different types of these foods. Again, add that to your previous answers. You eat takeout or fast food, 1, almost every day, 2, a few times a week, or 3, occasionally as a treat. Again, add that to your answers. The number of portions of fruits and vegetables you have in a typical day is 1, 1 or less, 2, between 2 and 4, or 3, 5 or more. And so you'll get a score. It ranges somewhere from 5 to 15. So a score of less than 5 means that that person generally answered 1s, and so they can make healthy changes in their diet. Things like adding more plant foods and limiting red and processed meats are going to be very important for them. If you scored a 6 to 11, you're doing well. You can swap sugary snacks for fruits and vegetables, and instead of the red and processed meats, maybe take in more fruits and veggies, cover more of your plate with those fruits and veggies. And if you scored greater than a 12, you're reducing your risk of cancer. You're doing a great job. Keep up the good work. So I feel like this could be a good tool to help you gauge how your patients are doing. And I understand that something we've been talking about is scope of practice. So obviously the registered dietitians are going to be the primary person that they want to talk about this dietary information with. But that doesn't mean that you can't help by giving some of the links to these websites and things like that to help them learn where they're at and where they can make changes. So what do we know? What does the evidence tell us? The one thing we know for certain when it comes to nutrition and breast cancer risk is it's really complicated. And there are all these risk factors that we have absolutely no control over. Things like the age at which you got your first period, genetics, height. No one has control over how tall they are. But then there are all these things that we do have control over, and nutrition is one of those things. And it's not the most important, but it's definitely one of those ways that we can make a change. So because of evidence like we've been talking about today, the American Institute for Cancer Research, and Dr. Klemp mentioned this earlier, has recommendations out for cancer survivors. And these are the same recommendations that we give for cancer prevention, and they're the same recommendations you would see for just anyone who wants to live a healthy life. So most of these recommendations have something to do with diet or physical activity. Number 1, be as lean as possible without becoming underweight. 2, be physically active for at least 30 minutes every day. 3, avoid sugary drinks, limit consumption of energy-dense foods, and we'll talk about that in a bit. 4, eat more of a variety of fruits, vegetables, whole grains, and legumes. 5, limit consumption of red meats, such as beef, pork, and lamb, and avoid processed meats. So the recommendation is no more than 8 ounces of red meat per week for cancer prevention. Limit consumption of salty foods and foods processed with salt. Don't use supplements to protect against cancer. Overwhelmingly, the evidence says supplements in and of themselves do not prevent cancer. If you can, eat diet forms or food forms of these foods. And it's best for mothers to breastfeed exclusively for up to 6 months and then add other liquids and foods. So this is another recommendation that the AICR gives. So a question that I get a lot from participants is, really, why does nutrition, not even participants, my family, my husband, does nutrition really matter? I mean, come on. Like, the message is so confusing. We get so many different recommendations from so many different types of people. Dr. Oz says one thing, my oncologist says another, the RD says another. It's hard to know if it matters and how it matters. So one thing that I have found really useful is going back to the data. And we know that over 374,000 cases of cancer could be prevented every year by achieving and maintaining a healthy weight, exercising, and eating well. And the majority of these are breast cancers. So 89,000 breast cancers could be prevented every year if you achieve a healthy weight, eat well, and exercise. I like to talk about nutrition being important for 2 separate reasons. One is for your overall health. So there are people out there who don't need to lose weight, and that's great. Nutrition is still important. They can't just go out and eat McDonald's every day, right? So nutrition matters for health in that it matters where you get your vitamins and minerals, how you get your macronutrients, which are things like fat, protein, and carbohydrates. Antioxidants play an important role, and phytochemicals also play an important role. These are things that are not necessarily vitamins or minerals, but components in foods that we know are cancer preventive. And nutrition also matters for weight, so something that I've already been talking about. How many calories, limiting calories is important. What kind of calories are you eating? Are you getting all of your calories from regular Coca-Cola or from broccoli? The portion of foods on your plate and the proportion of foods on your plate. So this is where things like serving sizes become important and label reading becomes important. And then again, the self-monitoring piece. So let's try to make sense of the evidence quickly. And I like to show this slide because I think it's really powerful in thinking about what people already know. And this is an American Institute for Cancer Research survey again, and they found that only 58% of people think that diet plays a role in their cancer risk. Only 41% of people think that activity plays a role, and only 39% of people think their weight matters when we're talking about cancer risk. So this is a big deal. People are misinformed or myth-informed. Other common myths I get from participants all the time are, will soy fuel my breast cancer? And the evidence really now says that soy foods are safe. You want to avoid those soy supplements. You want to avoid those really condensed soy bars or soy shakes. But 1 to 2 servings of soy foods are a great source of lean protein and can be a part of a healthy diet even for breast cancer survivors. Supplements. People think the more supplements, the better. I'll just take all my green coffee bean and whatever else Dr. Oz said that week, and I will lower my cancer risk. But we know that's not true. Food sources really are the best. Red wine, I'll talk about alcohol in a little bit, but red wine in any amount is good for me. I can't tell you how many times I hear people say this. And the fact of the matter is alcohol is a carcinogen. especially in terms of breast cancer risk. We know alcohol matters. The last one, sugar feeds cancer. Sugar feeds every cell in your body. Glucose is important for every single cell in your body. Now, I'm not saying go out and drink 17 regular Coca-Colas, but glucose is important. Carbohydrates are an important part of a healthy diet. Here's a link to the evidence-based guidelines that I've been referring to. The American Cancer Society has great resources. The American Institute for Cancer Research, obviously, what I've been talking about, has a great website. The CDC has a great website regarding guidelines for cancer survivors. And then again, your cookbook. All right, so here are some simple tips from AICR and the Back in the Swing cookbook. So I like to talk with participants about the new American plate. And this is just a really easy way to visualize what your plate should look like. 2/3 or more of your plate should be covered in vegetables, fruits, whole grains, and beans. And 1/3 or less should be have animal protein on your plate, be covered by animal protein. Another thing I like to talk about is energy density. So this is how many calories per gram are in foods. And low energy density foods are higher in volume and low in calories. So this is a way to eat more, but by getting less calories. So this plate of potato chips with dip, lots of calories, right? You can have 3 times, 4 times as much vegetables with low-fat dip as the calories that you would get in that plate of potato chips. Alcohol. There is convincing evidence that alcohol is linked to breast cancer risk. And this is just as low as 3 alcoholic drinks per week. And when I say drink, I mean 12 ounces of beer or a glass of wine, 5 ounces of wine. I don't know how many of us have a 5-ounce pour of wine these days. It's usually like a 10 or 12 ounce, right? But we know that it matters. And this little figure on the right side of your screen or on your page shows the risk of cancer for all different sites and alcohol intake. So we like to say there's a dose response here. The more alcohol you drink, the higher your risk for cancer. And this isn't a message that a lot of people want to hear. Lean proteins, there is quite a bit of good information in your cookbook about lean proteins and how you can incorporate them into your diet. But we know protein is extremely important. It's the building block. It also helps you stay fuller for longer, so it can help in this energy deficit that we're trying to aim for when we talk about weight maintenance and weight loss. 1 serving of protein is equal to 2 or 3 ounces, and so that can be equated to about the size of a deck of cards. Good sources of protein are things like lean meats, beans, eggs, whole grains have protein, and vegetable proteins. Low fat, what's the story on low fat? Again, good information in your cookbook about low fat. But we know extremely high fat diets lead to obesity. They lead to greater BMI, which leads to greater risk for cancer. You remember that J curve. As BMI increases, cancer risk increases, and we know fat intake does play an important role in this. But we know it's not just how much fat, but the type of fat. So we're just now kind of wrapping our heads around how different types of fat play into cancer risk. And I won't read these. I'm sure you all know the different types of fat. Trans fats are the fats you want to avoid entirely. Saturated fats in moderation. And then the unsaturated fats actually have been shown to be preventive in overall cancer risk. Again, plant-based. Fill 2/3 of your plate with plant foods. This helps with the energy density story as well. These are naturally occurring sources of vitamins and minerals, and the more color, the better. So this is also from the cookbook, and I think it just really nicely sums it up. The recipe for living well. Become aware. That's the first step. Then take charge. Establish control. And find balance. So practice things like monitoring your serving size and moderation. I think that's all I've got for you today. I like to always end my presentations with a quote by Michael Pollan, who says, eat food, mostly plants, not too much. I think it's as easy as that. So that's it.
Thank you, Danielle. Okay, we are. In her navigation through several personal losses and health challenges, including 2 bouts with breast cancer, she walks her talk by creating balance, joy, and meaning while teaching and helping others to do the same in their unique lives. Carol brings an honest sense of grounding in real-life practicality into all of her teaching and coaching. Carol LaBrue.
Thank you. Well, good afternoon. We're a lot of information to digest today. And I kind of liked it. Was it you, Bob, that called me Dr. LaRue? I kind of like that. And I would like to just say that I probably have a PhD in life. I come to this today from 2 different perspectives. I come from a perspective as a healthcare practitioner, as an occupational therapist, who actually for a number of years provided survivorship movement programs to breast cancer survivors, incorporating a lot of mindful movement. And then I also come to this as a survivor myself that totally caught me by surprise. And I'll talk a little bit more about that. But we're going to talk today about how to really not only help care better for those patients that come into your office, but start with yourself and care for yourself. So there's really not much today that doesn't apply to healthcare practitioners, just like it does to breast cancer survivors. The threats to our own healthcare and to the ability of breast cancer survivors to thrive following breast cancer are, one, we spend so much time focusing outside of ourselves, particularly healthcare professionals. You give a lot of your energy away. I mean, you're focused on caring for people. Anyone in a caregiver role does that. We're constantly meeting the needs of others, whether it's our clients, our family, our friends. And I know this one hits me big time. I have this taskmaster that kind of sits on my shoulder that says, you know, you need to do more, be more. Don't you dare stop and just be for a while. And that's a tough one. And then that all contributes to many times our less than optimal choices in self-care, whether that's what we are choosing to eat, how we're choosing to move, how we're choosing to relate to the people in our life, how we're choosing to rest and sleep. Worry and anxiety. This, as a survivor, is paramount. It's huge. We spend so much time out of the moment. We spend so much time worrying about what's next. You know, we did this presentation about 3 weeks ago to survivors, and I got an email the next day from one who said, thank you about reminding me to be in the moment. In my journey, I was so worried about the outcome, about getting through my treatment, that I forgot to pay attention to some of the pain that was going on in my body that was probably giving me signals. But aren't we all guilty of that? You know, we're constantly in the next moment or worrying about what happened in the past. Our resistance to change, just that need for control to keep things nice and safe and common for us. Personal and family illness and disease, everyday chaos, and healthcare. Sometimes I wonder if it is a misnomer, health care, when we are involved in craziness in terms of meeting the needs not only of our patients but of the government regulations and insurance regulations. And then stress, that big, 5-letter word, 6-letter word that is just paramount. And yeah, like Dr. Murray said, we need stress in our life, but where's that tipping point? And I think particularly as caregivers, we need to pay attention to that. When have we given so much away that we have nothing left? We know that 70 to 80% of illness and disease has a root cause of stress, of going over that tipping point that causes that imbalance in our genes. And the studies are showing that meditation, mindfulness can reduce the expression of genes involved in that inflammatory process, which every one of the speakers has talked about has a role in disease and in imbalance. And by reducing those levels of pro-inflammatory genes, after 8 hours of meditating, it's shown that it results in faster physical recovery from stressful situations. So I am a big believer in meditation, in mindfulness, and I practice it myself and probably wouldn't be here today if I didn't. We have 3 treats, if you will, to counteract all of those threats to our balance. One is in every moment we have the ability to choose how we respond and what we focus on. We have the ability to observe our responses and recalibrate if we need to. Oh, this response to this stressful situation is not working. I'm still feeling imbalanced. And our ability, this is powerful, our ability to change and adapt to what that is. Now, I shared a little bit, I am a 2-time cancer survivor, and both of my cancers were a result and came following 2 different types of stressors in my life. The first came after about 18 months of insult after insult from outside factors. I went through a divorce after 20 years of marriage. My business flooded unexpectedly. I had to uproot there. A few months later, my partner, who is now my husband, had a stroke, devastating imbalance to a lifestyle. And then 4 short months later, my daughter was killed unexpectedly in a car accident. And you talk about boom, ba-boom, ba-boom, and you talk about the trauma and the grief and the sadness that certainly has an impact. So I decided I'm going to take care of myself. I'm going to move down to Grand Lake of the Cherokees in Oklahoma, get out of the city, go to a place that feeds my body and my soul. 4 months later, I found a lump in my breast, and I was diagnosed with breast cancer exactly 1 year after my daughter died. And it was really clear when the radiologist said, you know, it looks like cancer. And it was like, yeah, I get it. I just experienced these losses. So I, rode on. I am a positive person. I've always been one to find the possibility in any situation. And I took that into all of my treatment process. I was grateful that I did live where I lived. However, I was out in the middle of nowhere with not a lot of support in terms of cancer survivorship programs. So I decided I was going to create my own. And I did. And I had studied mind-body health for years and came up with what's eventually in my book out there, The Art of Self-Health, and really lived, all of what is being talked about here today. So I decided to write the book, self-publish the book, and my second cancer was at the tail of my own self-imposed, oh, you need to get this book out as soon as you can and help as many people as you can. You know that taskmaster I was talking about? Push, push, push. Boom. Got my book out a month later, ready to do workshops, teach all of what I know, and boom, same breast, another lump. I thought, well, it's hard to explain. I was in such shock, and Barbara knows exactly how I was feeling, but I thought, oh my God, I just wrote a book on how to take care of yourself. How am I ever going to teach this? Again, I felt shame, embarrassment, and my process through that recovery was completely different, but the same. I didn't let go of the positive emotions, but I let myself really feel the feelings that are associated with that. I didn't write it up here completely. I really got down and got to business in terms of getting to know me and what I authentically needed for my recovery. And that's where the choosing and adapting. I really believe that everything starts in our mind, in our heads. And most of us spend 90% of our time up here in what I call our head bubble, okay? This is where we have those constant to-dos, we have that constant monkey chatter going on, and it feels like your head's this big sometimes and your body's just kind of along for the ride. this head, these next things to do are just taking you into the moment, and you're really not present in that moment. So it is important to notice what you're focusing on. How are you interpreting the events in your life? Energy does follow attention. So just like the survivor said, I wasn't paying attention to my body. I was too worried about what's next and getting there, that future. And for all of us, we have no guarantee even that future is even out there to be stepped into. So the power of giving your well-being, and this includes healthcare professionals as well, to plan to live and live your plan. Okay, be present in what you are doing and choosing the now moment. So what I would like here is a volunteer, if I could. Anybody want to participate in a come on down? Okay. Our thoughts do translate into emotions, and they translate into a physical response, and we're going to experience that here. Okay. So what we're going to do is, I was talking about the head bubble. Okay, the head bubble takes you out of your body. So I'm going to demonstrate a physical exercise, and tell me your name.
Nancy.
Nancy. Okay, Nancy's going to help. Okay. A way and a direction of focus that brings you into your body instantaneously. Okay. So there is a center of your body called the Dantian, D-A-N-T-I-E-N, associated with Chinese medicine. It's basically your body's center of gravity. And it's right here about 2-3 inches below your belly button. So everybody kind of puts their hand there, okay? Now, if we are up in our head bubble, up here, which I'm going to be right now, and Nancy's going to reach across and give me a shove, a push, gentle shove, right here. So go ahead and do that. I'm up here in my head bubble thinking about all the things I got to do when I get back to Oklahoma today. Okay. So I'm not here. I'm not grounded. I'm out here. So now, bringing my attention down to about 3 inches below my belly button, breathe deep into that, feel my feet, and now Nancy's going to do the same thing. More. Okay. Feel the difference. Okay. All of a sudden, I didn't gain 250 pounds or just get, ballast on me. It simply was a shift of where I took my focus. I could be talking to you, and I can still be centered. I can still be grounded. I could still be in the moment. And what that does for you as healthcare professionals is it allows you to be present with those people that you are working with. Because they'll know, just like you know, if you are, say, on the phone talking to somebody and they are on their computer doing something else, they're not with you. They are not present. And they will know that you are totally with them in that moment. And that in itself means so much. And you know what? It helps you too. Because you can intuitively even pick up more from that patient, connect with that patient on a level that you can't when you're up here in your head bubble. Okay? So bringing your attention, thank you, Nancy, here, now, which I'm going to have you practice, can make a huge difference not only in you and the choices you make for you, but in how you relate to the patients. So everybody stand up, partner up with somebody, and we're going to do this. Okay. So here we go. Stand shoulder to shoulder, side by side, like Nancy and I did. Okay? And just for the fun of it, whoever's tallest will be the one to try it first, okay? So take yourself, let yourself float right up into your head bubble, okay? And just go into your to-do list. And while you're there, your partner's just going to reach across and give you a nice firm little shove right here. Okay, whoa. So go ahead and do that. And then take a moment, center, bring your mental focus 2 to 3 inches below your belly button. I call this your home. You're in your body. Couple breaths, and then let that person know you're ready and feel the difference. Okay? And then switch off. Take a moment to switch. Huh? Yeah, that's okay. Yeah. Okay. Everybody have a chance to experience this? Okay. Isn't that cool though? I mean, did you get it? How many of you got it? All right. Okay. Now, this is a tool. Talk about toolbox. This is something you can keep with you every time, and it takes seconds. It just is a matter of being mindful to connect with yourself and be in the moment and be present. Very simple, very profound. Go home today, practice it with whoever's at home. Practice it with your partner. And you will be amazed at how much more effective the communication is. Practice it with your kids if you have little kids, in terms of just, instead of just off the handle, like be very present. More studies. Mindfulness-based therapies, whether that's yoga, meditation, breathing exercises, any kind of mental training of being in the moment, are an effective way to manage depression and anxiety in cancer patients. This is a way you can walk your talk. If you practice this, you can more easily guide the patients you're dealing with. You feel it, okay, and you can better teach it. Another study showed that the majority of cancer patients who participated in mindfulness-based therapies, stress reduction, experienced positive effects including increased calm, increased well-being, better sleep, more energy, and decreased pain. Guess what? We too, as healthcare professionals, can experience increased calm, better sleep. It's universal. It's a universal practice for all of us. So be aware of this center here, about 3 inches below your belly button. It just feels so good. And the thing is, you are relaxed and you're strong, both. Okay, yes, ma'am. Dantien, D-A-N-T-I-E-N. Yeah. If anyone's studied like Tai Chi, any kind of a mindful type movement, it's all about the movement, and the grace, the flow, and the strength comes right from here. Okay, any of the martial arts, the strength, flow comes right from the Dantien. Okay, so let's get up. We're going to feel this. I want you to stand up. Take a moment to connect with your home. Okay, but stay here. When you hear upbeat music, you want to get going. I want you to stay here and just move your legs. Feel grounding through your feet, but just feel your legs. Be mindful of what your legs feel like. Be in your body. You can feel your feet. You can even little steps, but stay grounded. And then feel your hips. Stay grounded. Can you move them fast and stay grounded? Can you move them slow and stay grounded? Okay. Feel your shoulders. Stay grounded. We're moving up, but we want to stay grounded. Stay in the moment. Feel it. Feel your body. Feel it. Breathe it. Be mindful of your breathing. Now, move your arms slowly, not with the music, and feel your arms, feel your elbows, feel the spaces between your fingers.
Stay grounded. Be aware of how it feels to move. Now get out of your center. Get crazy. Get crazy. Okay. Frenetic, chaotic, and then ground. And move. This is what it feels like. Feel the shoulders, feel the hips. Are you still in your legs? Feel your fingertips, feel your toes. Now breathe in big. And shake it out. All right. I'm shaking my watch off here. Okay, good. Now just stand here quietly. Connect with your center. And then just very quietly transition back to a sitting position and just notice how your body feels. So many times, okay, just take a minute and just, so what do you notice? Did your energy levels go up a little bit? Okay. How many feel like they're a little more alert now? Okay. How many of you feel maybe a little tingling? Fingers, toes. Okay, good. Okay. A little more warmth, perhaps? Okay, yeah. So you shifted that energy by staying home and in a very positive way. And we know that any kind of movement like that, it does affect our emotions. It does create endorphins. It does increase the serotonin level. We are much more positive beings when we move our body, and especially when we are more mindful and aware of how we feel. I know the question earlier was how did these people, they're overwhelmed. Survivors are so overwhelmed with all this prescriptive stuff. And I'm a true believer that, yeah, I 100% believe in exercise, the value of exercise and movement, and find ways to move that feel good. You know, walking is not for everyone. Going to the gym is not for everyone. I guess I can turn that music off, huh? Okay. Unless we want to keep that, okay. Pause. There we go. Yoga's not for everyone. Pilates isn't for everyone. And it's a menu of choices. And what's important is finding what feels good to you and what really feeds your body in a positive way. And for me, I know it's a menu. Some days when I was going through my healing process, each day I would get up and say, okay, what is it that I need today? What would feel best? Some days it was a brisk walk. Some days it was a more mindful walk. Some days it was yoga in my own living room because I was way far away from a yoga studio. But really encourage patients, and you too, to find ways that feel good. Relaxation. We are so involved in doing in life that most of us, many of us, don't take time to just simply be. How many of you here do practice some form of meditation or relaxation? Great. Study after study show the benefit of meditation on enhancing the immune system, on affecting those epigenetics, and affecting the expression of the inflammatory process in our genes, but really giving yourself permission to just not do, even for 10 minutes a day, is a huge step for many of us. How many of you can remember the last time that you just sat and did nothing? Okay, good. Okay, almost half. Okay. And if you can't, create it in the next 24, 48 hours. And it's so hard because we put so much value on doing. And we have got to allow our systems to rest and recover. Particularly healthcare workers, you are on overload. I mean, you are on this autopilot.
And this constant demands on how you use your time and how many people you see and all of that. I get it. And the only way, and your boss or whoever is not going to say, now you need to go back into the back room now and take 15 minutes of relaxation. Doubt it, right? The only way that's going to happen is if you take it and yourself. So being in stillness, being in relaxation is so good for the whole being. It really is a but it's also a oh, I didn't know this could feel so good. And it does improve your sense and your feeling of serenity, of wonder. You know, we become, I believe, so wise, more wise through our wonder and just being in that moment and wondering, you know, what if, and being very present with each other and with our environment. Love, joy, laughter, gratitude, peacefulness, and hope all spring so openly from that still point within. But until we access that still point, we have no idea of how good that feels. And so my challenge to you, my mission these days is to help healthcare workers take care of themselves. Because I think that we can be the worst because we feel like we're doing something so good for somebody else that we forget that it's important to do that for ourselves. And as Dr. Murray said, you know, the oxygen mask, I go back to our physical heart, teaches us the importance of self-care. That's why we have those coronary arteries. And that's why keeping those flowing and clear and clean gives us what we need then, gives the heart what it needs then to serve the entire body. And so you've got to start right here, each one of you. And I would love to share more with that with you. If you you better stick around because, oh my gosh, you won't believe what's coming up in terms of some goodies. But I've got two things for you. One, before you sample some of the goodies from the cookbook, stop and get into your center. And I will bet that you will enjoy it more because you'll be present and not thinking about, oh, I got to eat this and then get on to the next thing today. And two, take a minute. I'm doing a retreat for healthcare professionals, November 7th through 9th, out at Timber Creek. I don't know if any of you are familiar with Timber Creek Retreat House out in Drexel, Missouri. But the whole purpose, and whether you do this retreat or your own personal retreat, take time for you to fill your own cup again. And so you are more present and more full in terms of meeting the needs of the people that you serve every day. So can't express that enough. The turtle has been my mascot, if you will, since I moved down to the lake. I live on a little cove, and the turtles just kept showing up, and I thought, you know what, these things are pretty amazing. These turtles have been around for millions of years, and they're still around, and they're still around. And you talk about a message of resilience. And so I thought, okay, we all need to slow down a little bit. Slow down, breathe a little deeper. We need to learn how to adapt to change, just like those turtles. You know, they can be on a nice parched earth and then boop, into the water. Some of them go almost into the deepest hibernation for years and then come out, you know, alive and well and resilient. We need to be willing now and then to stick our neck out and create some change that we know will feed our body, mind, and soul. And then most importantly, be at home within yourself and really be authentic and true and take care of your home. Thank you.
Thank you very much, Carol. Okay, well, she already hinted that there's going to be some goodies coming. And to tell us about those goodies, I'm going to invite the co-authors of the Back in the Swing cookbook, Barbara Unell and Judith Ferdig. And I got a feeling you know Judith already. You know her, but you may not know her because you've read I'm sure, either articles from Judith. Her work appears in several Kansas City magazines over the last couple of decades. Can I say a couple of decades? Since fourth grade, thank you. She was the leading school student in her home ec class, I bet. And Judith is a best-selling, award-winning author of over 20 cookbooks, including, she says, thank you, the fabulous Back in the Swing cookbook, which, by the way, is a national award winner. The International Council of Culinary Professionals gave it its best cookbook in the health category last year. Her debut novel, this is really interesting. Now, this is not a cookbook. This is a novel. Is also about food. It's called The Cake Therapist, and it will be published in June of 2015. So excited to see that. And what I'd like to do, if you would give us just 1 second, hold on. We want to show you a little video that Anders McMeel, the publisher, actually prepared on the cookbook. And I think it'll set this up nicely.
I was diagnosed with cancer.
Because it's just a kick in the gut. You know, you lose your breath over
Every morning you stare in the mirror and you just see scars.
Is my cancer going to come back and my son going to lose his mother?
But I never lost hope or faith. I never did.
I was going to make it what I could.
And just to live every day to the fullest.
Putting each day ahead of me, never looking back. I really felt like I was back in the swing when I walked outside and that last radiation treatment was completed.
When I began to not wake up every morning and think, oh, I'm being treated for breast cancer.
That's when it all began.
This cookbook it's so uplifting.
Absolutely, is such an awesome tool.
This book is by far the best tool for an individual going through any kind of treatment or therapy.
And the hope is that the book will inspire and calm and actually help you to feel good as you are cooking in the kitchen.
Taking care of yourself first.
How do I eat? How much should I exercise? How to keep myself motivated and encouraged.
Little things you can do, common sense things, to help yourself get back in the swing.
It's not just for me, it's for our entire family.
That book is full of information and studies and
research in case you're interested.
You have the information, and knowledge is power. And power is strength, and that's motivational, that's inspiring.
And it's about living and healing.
You will hopefully feel calmed and centered and at peace while you hold the book in your hand.
it just opens up a whole new world for people.
It makes it look fun and exciting and delicious. I'm past being a survivor.
It's more than not dying. It's how you're going to live.
Simply put, the Back in the Swing cookbook is more than just a bunch of wonderful recipes. There's so much to know about food and what fortifies our bodies and what is a contributor to well-being. And this cookbook is a wonderful resource book to help all of us in the kitchen to eat great, to have wonderful meals, and to combine science with great common sense.
All right, there's Cheryl again. Okay, well, we're just going to take a really brief moment because you've been so patient and waiting so long, and I'm sure you're so hungry. But we do have a little sample of some of the fun things that are in the cookbook that that you're about to be enjoying. And I guess there's something about cooking, right? Cooking and what do I call it?
Cooking and getting in the kitchen and
I think I don't call it cooking. What do I call it?
I think you call it combining.
Combining. I call it combining. The reason I call it combining is that so many people say to me from time to time as we're going along, not so much to Judith, but to me, as I am not the chef person, I'm the researcher and the information gatherer of all the data in here. And Judith was fabulous to create these recipes based on those different things that Danielle talked about in terms of the guidelines. But they say to me, you know, I'd really love to use this book, but I just don't cook. Does anybody say that to you? I just don't cook. How many of you cook? Oh, look at you. But how many of your patients perhaps might have said to you, I just don't cook. I don't like to cook. Okay. All right. Well, that when they say that to me, then I say, no problem. Do you combine? And they're like, I don't know. maybe, maybe not. I don't know. What do you mean by combining? And I say, we'll take this broccoli salad. We'll take it actually out of the little plastic container, but take it and you can see what's in this broccoli salad, Judith.
Well, we've got some great steamed broccoli. We've got
green.
We've got some chopped red onion. You
Red.
could actually go to the salad bar if you didn't even want to chop the stuff yourself. You could load up at the salad bar with raw ingredients. We've got a little bit of grated cheese. We've got some raisins, and we've got some sunflower seeds.
Fabulous. And all of that, when you put it in a bowl, what do you do with it? You combine it. That's right. So this fabulous broccoli salad you're going to be eating here has all those colors that we've been talking about that are antioxidants and everything else that people have been saying. A little bit of protein, low fat, fruit, vegetables, but it's combined. It's not cooking. So people don't have to be afraid to make this fabulous broccoli salad. And in fact, this is the ultimate in combining. It looks a little shop worn, doesn't it? But but these are fabulous turkey roll-ups. And maybe Judith, you want to talk about that turkey roll-up?
Yes, we've got turkey. We've got a wonderful cranberry sauce that it's just amazing that, people make cranberry sauce at Thanksgiving when really you should buy bags of cranberries and throw them in your freezer and have them all year. They're great. They taste wonderful. And you could put this with the turkey and some fresh greens on a kind of a whole grain flatbread and roll it up. We tried to do recipes that actually are how people live. I mean, you got to have stuff you got to take to work. You have stuff you're going to make for your family. Are you going to go through your life and never have another chocolate cake? I don't think so. But you can have one that tastes great and it's got all the great things for you and that looks wonderful. That's probably one of my favorite recipes in the whole book.
Yes.
So, but I'm a cake person anyway. So,
And it's fabulous. And again, the 5 things that we talked about: lean protein, low fat, evidence-based food, plant-based, and as Judith said, taste good. So you're going to be eating the turkey roll-up. And then, okay, this looks a little like serious white stuff on top, but inside,
we've got, this is a carrot cake cupcake and a little one. So sometimes just a little treat is all you need. I think, somebody said life should be full of little treats. So you don't have to eat a giant cupcake, but you can eat a cupcake that's good for you, made with whole grain flour and fresh carrot. And in the top is a little bit of pineapple in the frosting. So you get really great flavor because if something really tastes good, you're going to eat less of it because you're satisfied. It's not one of those mindless things that you got to keep eating and eating because you're searching for flavor that just isn't there. So we wanted to make sure everything tasted great, so you can taste this too.
there you go. So we are going to wrap it up. The hook is coming, I see on my right.
No, you stay right here, and we're going to ask, if you wouldn't mind, Dr. Murray. Carol, would you step up here? And if you would take a cup, Danielle, and if maybe this would be a good time just to take 3 minutes and fill out your evaluations. I've been asked by Penny Schaefer of the school. You don't have to do it now, but I thought it might be a good time. And at that same time, I thought we'd ask these folks to come up if there are any questions you've been wanting to ask, you didn't get asked, and you can ask them now. Oh, well, here I come. Look at this.
All right.
And you guys, please use those handheld mics, okay?
Yes.
You must think I have a mic fetish, but the thing is, I want our video to have this sound.
For Danielle, what are your thoughts on juicing as compared to just eating the whole foods and having, because I've had many patients talk to me about that, and especially kale, which I find is like cow fodder, but, I wonder how people do it, but they say, juicing is so much better, whereas I think we're missing texture, we're missing color, and some of that stuff with juicing.
I think you're right on. And I'm kind of old school. I try to avoid the trends. So when you're eating whole fruits and vegetables, you're getting all of the fiber, all of the nutrients as it was intended to be eaten. You're eating the correct amount. So, how many apples does it take to make a glass of apple juice? I don't mean probably 20. So you're eating 20 apples in that glass. So it's a calorie story as well. So I say when you can, eat whole foods. If you're really into juicing and you feel like it makes you feel great, then fine, incorporate it into your daily routine. But make sure you're getting all the necessary macronutrients with that as well, like fiber.
I tell them to put some of the fiber back. After they've juiced it, take some of that stuff and put it back in there, because that's what's in that fiber is not only good for bulk and everything else, but it's got the nutrients that the good bacteria in your gut want as well. So there's a reason that foods are built the way they're built. They have lots of reasons for all the, and so juicing to me is sort of like the Western medicine thing of, oh, well, here's a plant. It's got a ingredient that helps us. Let's extract it and concentrate it and then make it into a pill.
Yes.
Whereas the whole plant actually has other benefits that we're missing if we do that.
Smoothies are also great. A great alternative to people who love to juice, because then you are getting the fiber. So.
I worry about our lower socioeconomic patients and so forth. I mean, I think, when I talk to some of them sometimes, their understanding of nutrition is so poor. And I do like the idea of writing a prescription to go walk twice a day, because they will do that. They will say, and I like the idea of combining, because they understand that. But I've struggled with that most of all with my patients and the patient population I deal with.
Nutrition literacy is actually a huge up-and-coming area of research in the nutrition field, and especially with low socioeconomic patients. I know there are people at KU Med who are looking at different ways that we can deliver this information in a way that makes sense. So.
And thank you. One of the reasons that you have, hopes everybody picked up their Back in the Swing pedometer, the Step Up card as well, that talks about the different research that Danielle wrote on the back, is why Step Up and why 10,000 steps and why movement is good. All that data there for you. The reason we did this Step Up to support breast cancer survivors, there's always a rationale behind what Back in the Swing does. And the reason we did it is to have that very simple tool. So just to be aware, again, and it was a really good point of Danielle's presentation, I think, and of Carol's as well, of just this awareness. In other words, what I always say is it doesn't cost any money to just have your brain be thinking about this. So I now think about when I just move, even to walk to my car. Maybe I just park my car a little bit further, right? Just a very old-fashioned kind of sense of that. And I hate to keep saying in the book, but in the book there are these very simple things. I think it's early on, like maybe page 16-ish sort of thing. It's terrible that I have that memorized, but of things you can do to start moving, and then put on the pedometer and see your steps. Back to the note about charting, that was a really good point too that I thought about when you were saying your presentation. Just having people write that down too. Along with your calories or along with what you ate, but thinking about, did you move or didn't you move? And sometimes I'm not even aware that how long I've been sitting somewhere. I don't even think about it. But simple things that you can do with folks that doesn't cost any money, and thinking about this awareness.
Back to the issue about food. I don't know if this is working. That it brings up some sort of social issues, like why is fast food, crappy food, high fructose corn syrup laden food cheap, and vegetables and fruits are really expensive? And it's because of food subsidies. If we didn't subsidize corn the way we do, and we subsidized, vegetables, it would be a whole different story. So many people live in food deserts where there is no place to go buy groceries that's in walking distance. And so what they've got is a quick trip and a liquor store and a gas station, and they can buy Twinkies and chips and Coke, and that's what there is. So it's a bigger social issue, particularly for low income people. And we got to rise up. I have a friend, Mark Hyman, who leads this functional medicine movement and has written books about health and so forth, met with President Obama in a committee about getting that exact issue changed. And what the answer was show me the grassroots movement for this. Well, okay, let's do it. Let's have a grassroots movement for, getting healthy food to be affordable. We can't do this minute right here, but maybe we've got some ideas.
Can I just wanted to say too that a lot of the tools that I was talking about cost nothing and can make a profound difference in the choices that people make. They've got to start where they are, and if you meet them there and understand what their situation is socioeconomically, energy-wise, whatever, just, coaching them on, okay, just pause a minute. How could you, get a walk in every day? Just start even walking around the house. How could you just pause for 5 to 10 minutes a day? Or when they get going into their anxiety, lead them through that same exercise I led you through. Let's just take a minute and just see how you feel after that. It costs nothing.
Getting back to the book and maybe in closure, I'd like to know, since it's holidays are around the corner, were those yummy muffins recipe in the book?
Yes.
Thank you.
Yes. Oh, the one we had for breakfast. Yes, it is also. Thank you. Yes, it is. They are.
Any other questions for this esteemed group of faculty, which I want to thank them all for participating in this. And if you just allow me to thank a couple other people, and then we can go.